us online and for all of those who are here attending in person, you're very welcome. Today, we are going to have a lighter day, but also very interesting, and I hope you'll be part of this conference until it ends. Yesterday, we had a very powerful opening ceremony, a very jam-packed but very interesting day, a powerful opening ceremony graced by Dr. Monica Monsenero, the Honorable, who's the Minister for Science, Technology and Innovations in Uganda. And she shared the strategy that government has for science, technology and innovations. But one of the key highlights that she shared with us is that there's wealth of potential in technologies generated in the continent that were unearthed by the COVID pandemic. And we need to leverage these technologies to cause transformation within our country and beyond. And she highlighted that it takes a mindset change for us to use these technologies to cause transformation, and that there's need for us to develop sustainable products that can affect and influence the economy and causing, reversing, the state of underemployment and contribution on the continent. And we had a very interesting keynote session graced by different speakers, and they shared the role of the pandemic in increasing the uptake of digital tools, but also they reflected on the challenges that they were in, the uptake of digital health tools. And of course, this included, the policy frameworks, the skills for digital uptake, and also, just skilling populations on using digital tools for health, but also the need to build resilient health systems that allow for uptake of digital technologies, but also the need to focus as innovators, to focus on human-centered designs, focus on the problem and sort out problems with digital health solutions, as opposed to developing digital health solutions and trying to place them within the system. So there was a clear call for collaborations, and this is what the HIC is about. It's about creating a platform where we can collaborate, and I hope that we can continue to collaborate beyond this conference. We had a plenary session about harnessing public-private partnerships, and it was clear that using this opportunity has its challenges. It was a very interesting conversation led by Dr. Ross. And of course, the concept of PPP, it was very clear that it needs a robust government strategy to allow its uptake and support. And we had different workshops and abstracts that I know many of you attended, and they were very vibrant. And thank you to all the moderators, the organizers, and the participants that were here with us yesterday. Today, I don't know, Martin, do you want to say something?
Not really. You really put it very well. I hope I'm audible enough.
Very audible. We can hear you.
Yeah, yesterday was a very interesting day, and we had wonderful engagements, as summarized by Dr. Ruth. And I hope today we close it up with more interesting ones, given that we are now moving from just the discussion of yesterday. If you look at the program, we're now going into the practicality of what we discussed yesterday. So yesterday we had discussions around, policy and frameworks, harnessing PPPs. But today's session will clearly highlight how far we can harness cross-border collaborations, because the regional bloc has formed the digital health roadmap for East Africa. And so what does that mean? How do the things that we discussed yesterday come into play in this session? So this will be a very engaging start to the day, and I hope our participants will enjoy it. Thank you. Over to you.
And now I would like to introduce my colleague. I almost want to call her Dr. Flavia, but Flavia Luvega, who is going to moderate the session, Academy Flavia is from the Academy of Health Innovations here at IDI, and she's going to lead us through the East African Digital Health Roadmap. Flavia, you're welcome.
Thank you, Dr. Ruth. Good morning, everyone. I would like to take this opportunity to thank you all for making time for the Health Innovations Conference. This is day 2. Good to have you here. And the session this morning is going to be about the East African Digital Health Roadmap. To put it in simple terms, the discussion is going to be centered on us having a one tool, a one system that is going to serve the whole of East Africa in the health sector. So we are going to look at how do we get there? How do we get to that East African digital tool within the health sector? So our discussions are going to be centered around that. And please allow me to go ahead and introduce our panelists this morning. So I'll also like to take this opportunity to thank our panelists who agreed to be with us this morning, to take the hot seat this morning, to be part of this session. The first panelist is Stephen Wanye, and Stephen is a digital health specialist with over 20 years experience. He has worked across the region, that is in Kenya, Uganda, Mozambique, Rwanda, Tanzania, and many other countries. And he has supported the development and implementation of the electronic medical records and many other information technology systems. He has also worked closely with donors like World Health Organization, the CDC, GIZ, and many others. Next, we have Dr. Judith Leo. She is a Tanzanian, a female data scientist, and she's currently working as a lecturer at the Nelson Mandela African Institution of Science and Technology. Next, we have John Paul Mbaka. Paul is currently the Assistant Commissioner, Health Sciences under the Ministry of Health. He is a statistician, and he has vast experience in M&E and database development with over 15 years experience in design, implementation, and M&E systems. Next, we have Badru Ntege. He has over 30 years of senior management as both a systems analyst and an IT consultant, both in the UK and Africa. And currently he is the director stroke co-founder of NFT Consult, a recruitment firm with offices in Uganda, Kenya, Tanzania, Rwanda, and Burundi, South Sudan, Zambia, and the UK. So a round of applause to our panelists. Thank you so much for making time for this session. So let's go ahead and dive into the discussion. So I think it would, for the interest of our online audience and everyone who is currently attending, I think it would be very good for us to first understand what is the standard. we are talking about having an East African digital health tool. So what should it be like? So I would like to pose this question to the panelists. Can we have Dr. Judith to take us off? What should this system, what should be the standard? Judith?
Hello, everybody. Can you hear me? Yes, hello.
Yes, we
Yes,
can.
Yeah, thank you so much, Madam Flaviana Lubega. Ladies and gentlemen, good morning to you all. All protocols observed. As introduced earlier, I'm Dr. Leo, representing Sanity at East Africa GIZ. I'm also a lecturer from the Nelson Mandela African Institution of Science and Technology, which is in Arusha, Tanzania.
Dr. Leo,
yes.
Dr. Leo, sorry to interrupt. Is it possible to put on your video so that the participants can see you? If that's okay with you. All right, thank you.
Yeah, I would like to contribute to the question posted regarding East Africa Digital Health Roadmap, particularly pertaining the standard data required so as to unify what we want to achieve in terms of the roadmap that we are creating. Yeah, first and foremost, the meaning of standard that we have in the health sector are the proper measures that are required to define the terms that are being used in terms of the data that we have in the health sectors. For example, we have a lot of health data that are common in each country, I can say particularly in East Africa. If you want to go to a certain hospital, you'll find that there are a number of issues that are very common. For example, there's consultation hours, there's also visitation hours. So all of these are some of the health data in the health sectors, which are supposed to have a proper format, which is unified for all East Africans. I'm saying this, the importance of this is to enable easy integration of health information systems among the East Africans. But currently what is happening is that most of the country, for example, here in Tanzania, we have different data standards. For example, we have HL7, that is Health Level 7 standard, which are used in the interoperability measures. We also have a new standard that is CPT for defining some terms. But we might find that just within Tanzania, we have different standards in different systems. To the extent that most of the information systems that are currently in Tanzania are not able to exchange data or are not able to integrate timely due to some of the challenges like different standards. Therefore, what I can say and what I can advise for further discussion is that us as East African, we should have a unified standard for all health data and other services that we have in our digital health activities. Yeah, for now, let me end up here. Maybe I'll come back maybe in the next question or for further discussion in the question and answers. Thank you so much.
Thank you, Judith. I also agree with you that given the fact that we are looking at having an East African digital tool, definitely we should be able to access our data across the region seamlessly at all times. So that is a very important aspect in regard to having our systems being able to communicate seamlessly across the region. So I would also like Paul, do you have any further insights about this question? Please unmute.
I don't know if I'm audible.
Very audible. Thank you.
Yeah, thank you very much. Just a mild correction. The name is not John Paul, but just Paul. You're welcome. Welcome, colleagues. Welcome, panelists. Welcome, all members present for today. Of course, I completely associate myself with the statements that have been made by colleagues, particularly around ensuring that we have standards to enable systems to exchange data. But of course, one thing that we need to pay attention to is the fact that the different countries in the EAC have different data protection laws. While some of these laws are compatible, while many of these laws are compatible, the operationalization of these laws as we write regulations and we set up data offices, the interpretation of the laws has so far not been done in the way that has facilitated the operationalization. So the environment might not specifically be ready to facilitate exchange. There's just broad interpretation. Our own concepts around data use have not been well articulated, and in that regard, we have impeded the exchange of data, which would have actually facilitated data use. It is also important to note that some of the tools that we've developed are somewhat clunky and not benefit those that typically provide this information from the get-go. So while we might be able to make systems interoperable, many times we have systems that are actually empty with information that is either inconsistent, incorrect, or have significant amount of gaps. So that really, even if the information could have been exchanged, the information generally presents itself in formats that are complicated to either use or interpret meaningfully. Thank you.
Thank you, Paul, for that point. Definitely, we have to, as we think about having a tool for that region, definitely we have to take into play that data protection laws that are governing the different countries, and then bring them together so that the data sharing can happen as this tool is being developed. So I think that would lead us into the current challenges. I think that is one of the challenges that we have different data protection laws within different countries. So what other challenges are we currently experiencing that we think will stop or might hinder us from having this tool in place? Judith?
Thank you so much again, Madam Flaviana. Yeah, I would like to share this slogan that we normally discuss with my colleagues regarding the health issues that are happening in East Africa. That is, better use of health data can improve health systems and health outcomes. I do agree with this statement due to the fact that if effective measures are being put in place related to data, we'll be able to achieve what we want to achieve in the East Africa Digital Roadmap that we are currently creating. There are several challenges that are happening. Maybe I can take you back to the very beginning at the start of the digital era that we started. We can all agree that most of the health sectors in East Africa have tried to move or to shift toward the use of health information system in different activities at their hospitals and other health services. But now what we have as one of the major challenge is a lot of data, we call it big data, which is unmanageable due to several challenges that we have. Among the lack of data being able to exchange from one system to another just within the country and also across East Africa, we have also other challenges. Particularly, there are so many of them, but due to the time, I'll categorize them into three. One of them is ineffective infrastructure that we have here currently. And also we have lack of capable staff or trained staff frequently based to the nature of what is happening. And also we have guidelines which are not updated to match with what is happening. Maybe I can discuss further what do I mean by ineffective infrastructure. Of course, we have a lot of infrastructure is in our health sectors, but you can see most of these infrastructures have challenges, including cybersecurity issues, data accessibility. We have interoperability, that is exchange of data, which we discussed earlier. And also we can see that due to this large amount of data, we are not able to manage such kind of data and also store on how or on effective manner. Coming to the lack of staff, we can all agree that in the health sector, we have limited number of staff. And also, most of the time, these staff, when you observe on how maybe they treat a certain data, which are very, maybe are supposed to be maybe private data, they do not treat such kind of data in a required manner. So there are issues like training, regular training that are required to make our staff capable to be able to maintain and use the existing infrastructure that are being created. And also coming to the guidelines, you might find most of the existing guidelines in the health sectors are still backdated. Therefore, we need to move with the pace of what is happening in terms of the emerging technologies, so as to have linked activities in all domains in the health sectors. Yeah, thank you so much.
And thank you, Judith.
Flavia, I wanted to ask, with regard to this, maybe just to put it into perspective, Paul and Dr. Leo, why should we have standards in the first place? What is the essence of the digital health roadmap? Why should we be bothered about having standardized ways of communicating as member states? Because you will see that we have a spectrum of challenges. We have diverse populations in Tanzania, in Uganda, Kenya, and now the region has exploded to include South Sudan. So why is it critical that we need to have a digital health roadmap for East Africa? And what does that mean in terms of accessing services? Why is it critical that the roadmap is a point of discussion among its member states?
Okay, now perhaps I can go first. Of course, if we have a place where we need to go, it is important for us to articulate very clearly how we need to get there. There are many ways that we could probably achieve what we want to achieve in terms of digitalization of the health space in the East African region. But if we come up with a clear set of activities that we need to do, first of all, to fix the problems around the environment, issues around infrastructure, like has been mentioned by Dr. Judith. And of course, the infrastructure here, sometimes when we talk about it, there is a lot of infrastructure that does not necessarily fall within our control, talk about reliable electricity and things like that. that we must put in place. So we must come up with a very clear set of activities that we must cost before we can achieve what we are striving to achieve. But that said, of course, I'm not sure about the environment in other countries, but in Uganda, there is a common attempt of local innovators trying to, for example, develop a car and doing research from scratch for things that have already been done. They're making mistakes that other countries made in the early 1920s. Colleagues who are trying to develop cars in Uganda today are making such mistakes. These mistakes are documented, standards are being developed, and you do not have to go through the same experience, suffer with the same mistakes before you can understand that there are better ways to do things. So there are global standards, global best practices that have been documented as some global standards. It is important for us to pick from those, domesticate them, and then implement them. But if systems are supposed to talk, there should be a common language. If any two individuals have to exchange information, if I have to talk to you, for example, it would not be wise for me to start speaking to Leo, for example, in my mother tongue. She would not understand what I'm trying to say. So it is important for us to come up with a common standard of communication. And that's why these systems must have standards, so that everyone who is expected to hear from the other knows that the information will come in a format that I'm expected to understand, because the format is already prescribed. And similarly, when I am pushing out information, I should push it in a certain way to enable those that are expected to receive it in a format that they expect, so that it is then easy to consume. If we have systems that don't use same standards, we shall waste significant amount of engineering time, because for every single system, you will have to have a customized way in which to interface with. That will require a lot of engineering time and result in a wastage of resources. But also, some best practices will be complicated to incorporate, because with every other system, you're relying on a completely different format for information exchange and different standards and so on. And some of the things that you do subconsciously, ensuring that security is guaranteed and so on, you would still need to do this very specifically, again, resulting into wastage of time. But of course, I'll let Dr. Judith step in and probably add into more light. Thank you.
Yeah, thank you so much, Dr. Paul. I think you've been able to capture everything that is supposed to be related to the question that was posted. Maybe to add a little bit on what are the advantages of having maybe a unified standard across maybe one country or across the region that is East Africa. If we could we have a unified standard for East African, it will facilitate optimized information exchange from one country to another among systems in East Africans. And also through this unified standard, we'll be able to achieve real-time integration, which is very essential in terms of obtaining required maybe proper health outcome that we want to achieve in this roadmap. Yeah, thank you so much.
Thank you, Dr. Judith and Paul. Stephen, you're welcome. Thank you very much, Paul and Judith, for the insights that you've given. I would like to Paul to further explain to us how, yes, we are talking about digital health from the M&E perspective. How shall we be able to go ahead and measure our success in regard to, yes, in regard to this, to implementation of this tool? What would we look out for?
Thank you very much. First of all, a project is a project. It doesn't matter whether it is a military project, a digitalization project, some livelihood project. A project is a project. If we are to meaningfully measure, track results and measure success in the digital health space, we should not come up with a new format. We should use common standards for monitoring and evaluation. Particularly, the log frame approach has been widely adopted and seems particularly attractive. When you have a log frame approach, you have a well-articulated impact you'd like to have. You break that impact into specific outcomes. That to achieve this impact, I would like to achieve these outcomes. And to deliver each of the outcomes, you come up with a set of specific outputs. And to achieve those outputs, you come up with a specific set of activities that would result into those outputs. Once you have determined what results you want to achieve at those levels of an output, an outcome, and an impact, it is important to come up with specific measurement matrices that can give you some form of sense that you have achieved the results that you want to achieve. These matrices are commonly called indicators. In the private sector, you would have them being referred to as key performance indicators. Of course, there must be the idea around a log frame approach is that all outputs must be reported in totality. They are not based on samples. If you say, I would like to train, there must be evidence that capacity has been built of a fixed number of people measured against the target. If you're talking around a result, results are typically contributed by multiple outputs. There are issues around external factors. Talk about, for example, if you have to digitalize, you need to bring in external players like those involved with setting up electricity infrastructure. You have just your own infrastructure. You have the telcos if you want to take advantage of the data coverage. All these must be contributed. But when you come to the outcome level, maturity models have proved to be a relevant way to check whether systems are mature enough or are having the impact they're expected to do. So at the outcome level, I think it is okay to take advantage of things like approaches like the maturity model to assess systems to see whether they are responsive to the goals for which they were developed. But there are also those national surveys, like in Uganda, for example, we conduct the National ICT Survey that checks the general environment in terms of ICT literacy, availability, coverage, for example, digitally enabled phones and others. All these are things that we must incorporate into the same evaluation framework if we are to assess the impact we are having. Because if we look at this in one stream and just focus on making sure the technology in place, there are things like attitudes of people, there are things like financing, there are things like other guys in the energy sector and so on, who will influence the success and the deployment of this technology. There are issues around the governance framework. Like, for example, if you look at Uganda, we are members of the EAC, we are members of the IGAD. EAC and IGAD all have different roadmaps for digitalization. We are all expected to align to them. So even the governance environment can somewhat be contributing to the success rate. So as long as we have measurement matrices and mechanisms to collect data to facilitate that would be important. The mistake that we've been making is that we have been enabling monitoring and evaluation in the rest of the health sector without doing monitoring and evaluation for ourselves. So we can provide to you the burden of malaria, the burden of HIV, but we find it very difficult to articulate progress in our own areas of work. Thank you.
Flavia, you're muted.
And thank you, Paul, for those insights. Moving on, Stephen, given your vast experience as a digital health specialist with over 20 years experience, and you've worked across the region, so many countries, could you share with us scalable strategies that you've interacted with that we could borrow in the digitalization of the healthcare sector in East Africa? Thank you.
All right. Thank you very much. And please let me know if I'm audible.
Yes, you are.
All right. Thank you. And my apologies for getting to the panel late. Thank you for the question. And I mean, I think, just listening to my fellow panelists in terms of some of the comments they have made to the previous discussion, I mean, I think they've mentioned a couple of things that relate to the question they've just asked. I mean, I think I would say for me, one of the main things is governance. I think, Paul has elaborated on governance and the importance of governance. And my experience in looking at all the things that determine, scalability, success, and effective implementation, I think governance is really becoming very clear. All the jurisdictions that, unless as countries, unless as a region, if we don't find a way of getting good governance models and operationalizing those in a way that actually works and enables the conducive environment for digitalization to happen, the other components that comprise of what's required for digitalization to happen and for the region to build a really robust, functional digital health enterprise are going to be very, very challenging. I mean, the experience that I've had working in my own country, Kenya, had a privilege to do some work in Uganda, Tanzania, Rwanda, nothing much in Burundi, but at least in South Sudan. The sort of governance challenges are very similar. I think as Paul mentioned, and I had that mentioned earlier as well before, digital health is a fairly new profession. What it means and what it actually ends up conferring in terms of value to the health sector, we are all grappling with in terms of understanding that clearly. And that comes with a lot of things, both at institutional and individual level. So individual level, of course, there are all issues around capacity. People need to be clear. They need to be comfortable that they understand what this thing means. And it actually fits in within their responsibilities and they're able to execute effectively and deliver results. Organizationally, and especially for government, there are a lot of many other things to consider. Government is responsible for its citizens. They have a legal mandate to take care of its citizens and its citizens' health. So issues around is this harmful? Is this beneficial to the country, to our citizens, for development and the health of our country? All those issues are really critical to be considered, and so for that reason, we are seeing a lot of countries coming up with legal frameworks, especially around data. Data Protection Act and all that. What it actually means, health data for a long time was confined to health records management. But now I think everyone recognizes that health data, which is really what digital health at the end of the day is about, it's really an important component for service delivery and for improvement of health and health outcomes. And for that reason, it's not just what used to be confined to managing big chunks of files, purposes of M&E reporting and all that. Now, there's a very clear correlation between data and your health. And so governments are taking this a lot more seriously. And so digital health as an enabler becomes all more important. And as we know, then government has to really think through this clearly. So I'd say for me, a direct answer to your question is number one is governance. For me, that's really, really priority. The number two, I think, is partnerships. Partnerships, especially public-private partnerships, really, really important. I mean, for a long time, everyone knows the role of government, individual governments and also the regional governance structure, through ESC, IGAD, as Paul had mentioned. But the partnership between the public health sector and the private health sector has, I really honestly can't think of any country in our region that has done that really well. I think we all at different points of implementing that, but I think over time it's becoming very clear to everyone that that partnership is critical for significantly improving how healthcare is delivered through digitalization and digital transformation. I know countries are really working hard towards that, and that is very closely linked to sustainability. We keep talking about how do we sustain our digital health investments. It's through partnerships. How do we ensure that we pay for our own investments and we leverage what our partners are able to support us in. But primarily, have the pride, have the authority and all that to pay this for ourselves is through partnerships. Government has a role, private sector has a role, and that partnership would, in my opinion, be a game changer. So also for me, those are the two key things. But then the third thing, of course, is capacity. Digital health is fairly new, so a lot of our universities are now, upgrading their curriculum. Now we have a sort of standardization in terms of a competency framework for digital health and health informatics in East Africa. Really great move, progress for the region. But still, within our own health sectors, if we're really honest with ourselves and we do a capacity assessment, we're not where we're supposed to be. So even in terms of government and our ministry service schemes, how many of the ministries of health have digital health experts as a recognized legal job position? So there are those kinds of things that I think take time to work through, both in service and pre-service. But for me, those would be the three top things. Everything else sort of falls under that, including financing, infrastructure, and all that. Thank you very much.
Thank you, Stephen. I would like to urge our online audience to please share your questions and comments. Our panelists will be answering these questions. So moving on, Judith, given your current work, what could you give us more insights about some of the platforms that you're currently using and what learnings we can pick as we focus our efforts on the East African digital tool? What learnings from your current work can we borrow?
Yeah, thank you so much, Madam Lubega. Yeah, since I'm at the university, there are different kind of learning that we have, and also different collaboration that we have with the Ministry of Health, where we participate in terms of implementing different learning platforms and strategies. What I can share, what has been done so far in Tanzania, is that recently we have this platform, we call it Tanzania HIM. In long form, we call it Tanzania Health Information Mediator, which is one of the very, very powerful system that has been implemented in the Ministry of Health regarding monitoring and evaluation of how data are being exchanged within all domains or all the systems that are recognized by the government in terms of sharing data or sharing services. So this is one of the platforms that we are using, and I would wish other countries also maybe to look into, maybe try to tap into so that they can implement if they have not implemented such kind of a system in their country. Other platform that we have here in Tanzania or at the institution that I'm working, there are issues that are dealing with the emerging technology that are existing, such as artificial intelligence, embedded systems, mobile application, data science, and the like. But what I can say in general, what we're supposed to have as East Africa in terms of the roadmap that we are creating, we should have a certain platform where we share our successes and also challenges that we have, because I believe that different countries have different implementation and platform that are very successful, and some of them have a lot of challenges. But if we could have this kind of shared platform where we share everything that we are doing in terms of the success and challenges, I think we'll be able to get somewhere in terms of what we want to achieve. Yeah, thank you so much.
Thank you, Judith. I think it's very key that on a regional level, it would be good for us to share the learnings, just like Dr. Judith has said. We need to share. There are some achievements, key achievements, or good projects that we've had in our different countries, good implementations that we've had in our different countries. So I think there should be a platform where these learnings, the lessons learned, are shared, so that I believe that this would help in implementation of the digital solutions in the various countries. So Stephen, back to you again. How have you managed, or how is knowledge management being implemented currently in your country to pave a way for the digital health tool? How is it being implemented?
All right. Thank you very much for that question. So there are a couple of strategies that the Ministry of Health is using to do that. One of them is that, excuse me, the ministry has, one of the things the ministry did was, first ensure that everyone shares its vision by developing the e-health strategy and a couple of other policy documents, just to make sure that we're really all looking at this in the sort of shared way and shared manner. So then once that was achieved and the ministry got all its partners on board, then out of that naturally came various strategic areas. So as you say, one of them is knowledge management. So what the ministry has done is that it has defined where knowledge fits in within its broader strategy with regards to supporting it achieve its mandate of delivering quality healthcare to all Kenyans, which is really a legal mandate that they're required to carry out. Then out of that, the ministry held a couple of information and engagement meetings, created the relevant technical working groups, like I think all of our countries do. And then out of that, they came up with, which I've been part of those, came up with what needs to be done and invested to create a knowledge hub. So there are a couple of, so I would say the design and the architecture of the knowledge hub is not so different from what you find in other countries and even globally as well. So from a technology perspective, there are all sorts of tools, open source tools, and the Ministry of Health and the government of Kenya generally subscribe to open source, free and open source, and the concept of global goods. So everything that's developed in the country is, at least in the public service, is open source. So then the technologies are really not so different from what you find elsewhere. But I think more importantly is really the governance process and the use strategy around the knowledge hubs and the knowledge assets, and then who's playing what role. So at the end of the day, the ministry is responsible because the knowledge, synthesizing the knowledge and ensuring that it fits into a broader strategy, whether this is for service delivery or is for setting research priorities. That is what took a long time to craft as a strategy. So looking at the health research institutions in Kenya, led by the Kenya Medical Research Institute, who are always generating evidence-based information to, for policy purposes and practice purposes, and how that jumps from research to practice and trying to reduce the no-do gap. And then once that is done, how that then translates into affecting and influencing service delivery, and also influencing how digital health tools are developed. Now, one of the interesting things that I want to mention that it's a very recent development in Kenya and Ministry of Health is, I'm sure some of you might be probably aware about the WHO's SMART Guidelines initiative. So SMART Guidelines, so SMART is an acronym which I don't remember what all the letters mean. But it's basically a very innovative recent development led by WHO, where the idea is to try and translate the clinical guidelines and the protocols as you know them into machine readable artifacts. So if you take an example of, let's say Uganda has done research in COVID, and they've come up with a novel way of managing COVID, developed protocols, maybe even treatments and all that. And that's been done, let's say, through the classic clinical trial. Then once that is done, it goes through the usual protocols of government and research ethics and all that. and then it becomes a protocol and a policy for how to manage COVID in the country. Now, that will be adapted. We know from a global perspective, WHO does that with its member states, Uganda and the other countries in Kenya included. Comes up with an evidence base, and that's what influences global practice in terms of service delivery and protocols. Now, the challenge has been translating those clinical protocols, which are usually PDF, they're usually voluminous documents, into something that can be used in digitalization. So when you're sitting with a software team, business analysts and all that, everyone involved in digital health and digital transformation, the business analysts have to translate all that very heavy, voluminous, deep knowledge into something that can be used in the software that then becomes a tool for use by the frontline healthcare workers. So that is a knowledge management issue, in our opinion. And so Ministry of Health has been working closely with the WHO around this concept of smart guidelines, which I encourage everyone to look at. If you go to the WHO website, there are various levels from L1 to L5, with level 1 being the really basic where every country is at, with the usual PDF documents and all that, and L5 being the most advanced, where for digitalization purposes, we'll have software artifacts that are based on this clinical and scientific evidence for informing how we build digital tools. So I think I'll say in a nutshell, that's what's going on in Kenya. But beyond that, there are a couple of other initiatives with different partners to harvest and harness various types of knowledge, including what is formal knowledge and informal knowledge, gray literature and all that. And there's even actually an initiative led by Ministry of Health to harness indigenous knowledge, including what we call that in Kenya, mitishamba, traditional medicine and all that, because there's a whole hub of knowledge there, and trying to consolidate all that into a knowledge hub with a very clear system and infrastructure and framework around it. Thank you.
Thank you, Stephen. Martin, I see your hand is up.
Yes, Flavia. Just to the panelists, to go to the practical sense of it, when we had COVID, what we envisioned as the low-hanging fruits that the roadmap would have delivered by now were not realized. It was very hard for people to cross borders at the most basic of times, and we thought that maybe very simple tools could have been harmonized between the regions, but that wasn't possible. So even for critical goods to move during that time was really hard. And the roadmap has been discussion. A few low-hanging fruits were promised, but we did not realize them in times of COVID. So to the panelists, Paul has been at the heart of COVID and making sure cross-border movement is manageable, as with regard to the MOH SOPs. But again, there was a lot of gaps that exposed. So I do not know how we can relate the experiences from COVID to inform what initially was the point of discussion. So how different are we going to approach this, given what COVID has revealed about the strategies that were earlier being discussed? Why couldn't we easily track and monitor if we had achieved some low-hanging fruits of this digital roadmap? Because it is very convoluted to realize it all together at once, and the implementation is by phase. So at the point where we realized there was some achievements when COVID hit, that wasn't as previously envisioned. So to the panelists, to Paul, what could have been done different since we are learning from the pandemic? What low-lying fruits did COVID inform about approaches to basic standardization of movement of data across regions to enable critical services in times of a crisis like COVID? What can we do different to achieve the low-lying fruits of this roadmap, given that the wholesomeness of it is hard to achieve at once? But from COVID, what have we learned and what are we going to do different? Because it was tested and failures were across all borders between Uganda, Kenya and its neighbors and elsewhere.
All right. Thank you very much. Okay, first of all, allow me to correct the statement you've made. in the East African region particularly, there are some successes to take note of in terms of how cross-border exchange of information worked well. During the early times of the pandemic, maybe around April, May, June 2020, when there was the initial lockdowns across countries. Of course, like you have rightfully noted, there were some complications associated, particularly with goods moving across the border. There was a tool implemented by the East African community to track drivers across the border, understanding because they had designated points where they had to stop and make sure they stick to prescribed routes and so on to facilitate monitoring their health, the checks they have to do, and really to prevent the disease from really moving away from those designated places, and also to make sure that all those that cross borders are tested. The tests are verified by the different countries and then are exchanged. This tool worked very well. However, when we opened the border beyond the truck drivers, it was somehow complicated to scale it beyond truck drivers. And actually, even that we had implemented for truck drivers could no longer work because those that were not truck drivers were somehow being led to cross because the tool had not scaled beyond those that were driving trucks. There's a very good lesson here that we need to pay attention to. First of all, it is important to have a broker for the exchange. So, for example, here we had EAC, who was a trusted broker. Uganda trusted EAC enough to exchange the information with it. Kenya did the same thing. Rwanda did the same thing. Tanzania the same thing. South Sudan did the same thing. So, without a trusted broker, it is difficult to exchange information. It is impossible for Uganda to have a separate deal with Kenya, with Tanzania, with Rwanda, with South Sudan, with Congo on how this exchange of information can happen. That said, it was complicated to implement some of these things given the number of potential brokers that were engaging the different countries. At some point, we failed to exchange information just because all of us adopted different initiatives. For example, we had the East African community trying to implement something, and maybe some countries were on board. We had the African CDC trying to implement something, and you have IGAD trying to implement something. And sometimes these organizations are either talking to each other or not. So you have a country trying to respond to these multiple brokers, and there is no one who is trying to hold the thing together. So up to now, there are still discussions that are going on to see how these things can happen. And the impossibility is largely because you have entities that should be talking to each other. You have WHO, you have East African Community, you have African Union, you have IGAD, but each of them is approaching the country on their own without any engagement at that level. So you would expect that if you accepted to trust the EAC and exchange data with them, somehow the data will trickle across, but that is not happening as it is now. The other mistake that we made is that some of the initiatives that we tried to deploy were not aligned with the work on the ground. For example, you can come up with a tool that is not aligned to the surveillance initiatives of the countries. If the surveillance officers who are the ones going to benefit from this data do not already have that kind of understanding that we will be able to access this information from these platforms to help us with these specific purposes, and the information we require are these specific data elements or these specific indicators, then even if you exchange the data, sometimes the data would lie redundant. So we failed to align the systems we set up with the programmatic work that we're deploying in regard to the cross-border initiatives. But also we had all these regional actors who were not talking to each other, even when we tried to point them to each other. Say, listen, we already engaged with this actor. Can you guys coordinate at that level so that we do not have to interface with everyone and so on? So for example, you have one country engaged with one actor and trying to exchange information with that actor, hoping that the other country will access. And then this country is exchanging the data with a completely different actor, also hoping that the others will access it. So you have a system that ended up being completely disjoint because of the competition between these regional actors. So if we are really to be able to make progress in this regard, we have to figure out how to get these regional actors that can really strategically act as brokers for the exchange to really be able to interface and work as though they were responding to the same thing. Thank you.
Thank you so much, Paul. Maybe just to add on to that, maybe we can get Stephen and Dr. Leo's perspective, since they're also from different countries and they were active during the COVID pandemic.
Yeah,
I don't know how, Dr. Leo, you relate to that situation that we faced as a bloc during COVID, what Paul has highlighted, what worked and what didn't work. What was the case for Tanzania? There was a latency in joining some of these initiatives. Then Kenya had, I think, quite a number of initiatives also to make sure that they were facilitating information exchange with member countries. So maybe you and Dr. Leo and Stephen can maybe come in and, respond to what Paul has been highlighting also.
Okay, thank you so much, Dr. Martin. I think Paul has captured most of the issues that were happening. Maybe just to add one point that we should also look into is to try to separate maybe political issues and science, or try to integrate science with what is happening in terms of politics in our countries in East Africa. That's what I could point out sincerely, that we should try to separate politics and science so that science activities can have a chance to move on as how they've been planned for effective measure in the science domain. Yeah, thank you so much. That's what I wanted to share.
Yeah, and I could probably also extend Dr. Judith and Paul's comments earlier. I think I would say I would probably just emphasize what Paul has mentioned. I think the initiatives are there, the technologies are there. I think we know what needs to be done, but there's definitely currently a not very effective model for collaboration, especially by what Paul is calling brokers. The importance of cross-country collaboration, or rather, one of the key components of cross-border collaborations is what Paul is calling a broker. That's the role of the regional organizations, as is listed them out. And you're right. Unfortunately, there's a lot of overlap in their interests, in their mandates, in their functions. Most of us have been part of the different initiatives, really well intended. But at the end of the day, they don't achieve the much needed impact and improvement in efficiencies as they can. And they can do that even with reduced resources, if only there's a mechanism to have them sit and agree. I think at a global level, we are seeing a lot of efforts towards addressing the same challenge. So for a long time, and in most of our countries, we know that fragmentation of systems has been a big issue. And the global community has, over the last couple of years, admitted that a big reason why that has been the case is because of our development partners, donors and all that. Now, if at the global community they've come up with the principles for donor alignment, I think we need to apply the same approach towards what Paul is saying, and I believe that's gonna that will actually solve a major challenge. Specifically, I can list a couple of examples where, for example, Paul and I have been on similar initiatives with EAC, for example, through the Regional East Africa Community for Health, with IGAD on the regional action through data. They're all efforts towards enhancing and strengthening cross-border collaboration in terms of data sharing, in terms of like what Dr. Judith mentioned, using a health information mediator, which is becoming like a global standard now, based on the OpenHI framework, and all that. But again, it's really those soft governance issues across the investors, in this case, also the brokers, that needs to be cracked. And whether that's coming from a political perspective, from a health financing perspective, but that needs to be solved if we're going to achieve this regional integration and better use more responsible and ethical implementation of digital health and data sharing. Thank you.
Thank you so much. Flavia.
As we move to the end of this session, I would like to also pose a question to the panelists. Yes, we've had COVID and it hit us, and we were not ready for this. However, over time, we've seen other countries being fast at responding to the different problems that have come up. However, within the East African region, and I believe all of us will testify to this, we see that the problems exist, the problems that have been brought about by COVID. However, we don't seem to be providing the solutions. We know the solutions, but we don't seem to be, should I say, like vibrant or responding, giving a prompt response to these problems. For example, Martin talked about testing at the border, but also at the airport. Recently on the social media platforms, there've been stories about people coming in at the airport and they have to spend over 4 hours waiting for their results, COVID results. So we've seen other countries that have embraced these. For example, if you've been able to test within the 72 hours, then whichever country you're going to, you don't have to test. Or if you test, then you go ahead and have your results on email, rather than waiting in a queue. So my question is, how can we be able to promptly respond to the different challenges that we are faced with?
Well, I don't know if I can take a go at it, but because I perhaps we are okay. So thank you very much for this question. This question is a very it's a very important question that we need to ponder closely. One of the challenges that we have is that many times those that provide or provide some of these digital solutions try to they shy away from some of the technical non-technology discussions. Once these discussions have taken place, like for example, if the colleagues in surveillance are trying to prevent an importation of the disease, they will come up with a strategy. They will say that, okay, we want to test people, and after we've tested them, they must sit and wait for their results. And once they have sat and waited for their results, we must print them and give it to them. If we who are able to provide some guidance in terms of how this technology solutions can come into this space and enable the process, do not come at the point at which these things are being thought about and come at the tail end only to digitize a decision that has been made. We shall always come up with digital solutions that don't help to solve the problem, but just implement the decisions that have been made. This is one of the things we've observed. These are one of the things we've observed with COVID. There must be better participation of those that provide these technology solutions in the very infancy of when these ideas are being considered. In that way, we can already embed the abilities and the technology that is available to support in the delivery of the intended service. The problems that we have is that the technological considerations are usually made once the policy decision has been made. In that way, you only end up digitizing whatever decisions have been made. And so you do not necessarily help with solving some of the problems. You do not point out where technology can be leveraged to do things differently and articulate some of those policies in such a way that they of course provide the convenience that is required. Because if we don't do that, we shall end up with the scenario that we have, and this is not happening only in the places that you prescribe, but you will notice that if you go to any health facility, most especially a public health facility in Uganda, where an electronic medical record has been deployed at a point of care, the waiting time just goes up. It does not help with reducing waiting time, and the doctors just revert back to a paper-based system. So there's a lot of thinking that we need to do around how to make technology solve the problems that exist rather than just digitizing the record. Thank you.
Thank you, Paul. Stephen, Judith.
Yeah, thanks a lot for the question. And I think, as Paul mentioned, it's a loaded question because it touches on multiple levels. I think Paul has explained very clearly, excuse me, especially I think about the planning process and that we need to think about these things in advance before the decisions need to be made. So that sort of engagement process with all the different stakeholders, the different contributors to solving the problem needs to happen way in advance. Excuse me. I think the thing I wanted to highlight, in addition to what Paul has mentioned, is really just this concept of standards. And I know Paul spoke about this just when I joined the panel. That is really, really critical. I mean, COVID, of course, is a pandemic. It's a whirlwind, happened very fast. Things are moving too fast. So we don't have the luxury, or probably most countries in our region didn't have the luxury to sit down and think through standards and all that. But now that there's a general containment and progress going on in terms of management of COVID, I think we need to really work, and I know every country here is represented is working closely with the global community in terms of putting in place structures that are going to help us next time we have a pandemic. Because it's not when, it's not a question of if, but when. And one of the developments that is going on, which I know again many countries, Uganda, Kenya, and Tanzania, and others in the region are part of, is really this concept around this concept being called the digital documentation of COVID-19 certificates. So you might be aware that WHO developed some guidance and technical specifications in terms of the document exchange around COVID certificates. So every country is testing people, issuing out documentation to demonstrate your results and other important information. But those documents and that documentation is not exchangeable. And that's part of the major problem. So again, many countries, including our own region, EAC and others, have tried out different initiatives, there's EAC Pass and all that. But more and more countries are realizing that these siloed efforts and way of working has very limited efficiencies and impact. And if we don't underpin that on standards, like what I've just mentioned is going on, so for example, why now on developing a system to support COVID-19 management, whichever aspect of that is, whether it's testing, treatment, and care and treatment and all that, is not basing their system on the technical specifications developed by WHO on COVID certification, is anyone's guess, because you're basically exacerbating the problem. But again, that then connects back to the role of government and governance to ensure that these best practices and standards are actually implemented, whether it's through a certification framework, through education and all that. So I think for me, those are really really, really important aspect that needs to be taken into consideration very, very seriously and operationalized as expeditiously as possible. Thank you, Flavia.
So we could go to the questions in the Q&A. Annette, are there any questions for the panelists?
There's a comment from Francis. Francis highlighted that, and I think when you responded that there's some ongoing models by some agencies like Sanalytica, and they're using off-grid to empower just let me read it out. Francis says, regarding private-public partnerships and infrastructure setup, there are efforts already being made, such as Sanalytic Uganda, whereas without internet, electricity, etc., they are setting up off-grid solutions. For example, solar that can speed up the uptake of EMRs and other health tools. So he goes on to ask, how easy would it be to use this as one of the key models in the roadmap? I think Paul and Stephen and Dr. Leo can respond to this, because most of our population is not connected and issues of infrastructure have been raised. And Paul mentioned that we need to look holistically beyond just the systems, but other enablers like energy and people's attitude and perceptions. So leveraging the not so complicated solutions like the off-grid could potentially answer the question to making sure interconnectivity to enhance coverage would be leveraged. I don't know if there are models in Kenya, Dr. Paul and Dr. Leo, that you can speak of with respect to this.
Hey, Martin, I can take a quick one because I attempted to respond to Francis in the chat. So I think, I definitely agree with Francis because I think physical infrastructure is one way that you can demonstrate value and impact really, really fast, and especially with the different models like PPPs. I think it's possible to do that. The point I was trying to make there is that I know many governments, including Kenya, Uganda, and others, have different programs that are focused on last mile connectivity. Like once you set up a grid, and then there are those hard and far to reach areas, they're exploring PPPs now for that last mile. And I really think it's something we need to do. It's also very clear that not just in this East Africa region, but in Africa, especially the tropics, we're really not utilizing God-gifted natural resources like solar. Yet that would solve such a major problem. But yet, because that may not necessarily be what government is really well set up to do, that would naturally be achieved a lot more easily, effectively, and to the benefit of the whole community through a partnership. So I was just agreeing with Francis and saying that in Kenya, there are those initiatives by Ministry of Energy, working with its partners and all that, and it's really working out well. But government involvement is really critical, in my opinion, because I look at government as like when you're doing city planning, this is an infrastructure. And government has a very major role to play, but they don't need to do it themselves, but they just enable the environment for that to happen. Thank you.
Thank you so much. Dr. Leo, any initiatives in Tanzania that are leveraging off-grid to enable connectivity to hard to reach places?
Yeah, thank you so much, Dr. Martin. Yes, in Tanzania, we have a large number of initiatives that are being done towards trying to capture or cover up the gap that we have between the rural and the urban in terms of the connectivity. Yeah, we do believe that most of the rural areas in East Africa are not yet fully covered in terms of the internet accessibility. But what we have done so far here in Tanzania, we have some innovative implementations that do not really rely on the use of internet, but on the use of solar, as Stephen has just shared here, and also on the use of mobile application or USSD's application to exchange such kind of information from such kind of services regarding health activities. Therefore, there are a number of activities that have been done and also implementations in terms of ICT without the use of internet, so as to enable data sharings on timely manner. That's what I can add to what Stephen has just shared. Yeah, thank you so much.
Thank you. Maybe just to close one question that we always try to get in designing these, standardized ways of doing things. With standardization, there is always a chance of leaving certain people behind. And given the diversity that is in the East African bloc, what are the guiding principles to approaching standardization? Because with diversity comes issues of social differences, languages, cultural norms, professional practices being different across the borders. And, it can cause friction in the adoption of and implementation of some of these solutions. So from your experience, since you're working on this project and other related projects, what are some of those key aspects that are informing standardization of practices, data sharing across the borders? Maybe we can start with Paul. I'm sure he also relates very well with diversity within Uganda. So when you're trying to create standard of principles that speak of standardization, the likelihood of leaving certain aspects with people populations is quite critical. So what are these general principles that we should be mindful of when we're trying to create standardization of protocols, frameworks to guide implementation of such big projects? Thank you.
Thank you very much. Of course, it is important to develop any standard or guideline in such a way that it is not cast in stone. First of all, it should allow for flexibility, but it should also allow for revision. If you look at most of the guideline frameworks that are developed, particularly in the health sector in Uganda, there's always a section that articulates the process of updates. So if there's new knowledge or new evidence, there are the opportunities for consideration and incorporation. That said, of course, in an attempt to standardize, I must say that Uganda, whether when you look at our Vision 2040, whether you look at our National Development Plan, or when you look at our health-specific strategic plan, there are statements there that call on sectors to adopt innovation. So we are not in the business of stifling innovation. So there's really, even our own strategies provide for such opportunities. The challenges that we currently have is that innovators do not know how to engage. So many times they innovate in a disjointed way. Then if they come, either it is something you've tried and it has failed, or it has not taken into consideration what is available, and so on. But also, while you come up with these standards, of course, there's just generally issues of equity that you must pay attention to. There are vulnerable groups. There is potential for misuse of data as you exchange it from systems to systems. So if you come up with standards that is only going to make it more efficient to exchange information, of course, you open it up for better abuse. I keep telling guys that, right now we have very good data protection mechanisms because we have a heap of paper And when you are looking for my specific record, it can take you 100 years to find it. But if I bring this data in an efficient electronic system, then it becomes easier for you to either query or to hack or to use whatever other mechanisms you can have to pick this information and use it in whatever unethical or non-sanctioned way. So there are such considerations that must be made. It is not exactly a straightforward thing to do. It is not uncommon for regulation to follow innovation. And this is really where we are as we try to incorporate, to make sure that our systems can exchange data efficiently. We do not know all the answers. And this is where we need close collaboration, most especially with academia, so that they're aware about the challenges we have. Because some of these things might be obvious in the academic sphere, and yet we are here struggling with how exactly to do it. And so this is where we need collaboration to ensure that we do these things very well. It's very possible for us to come up with rules that are even prohibitive. And yet, if we engage with those that have looked at this more critically and reviewed practices in other places, they can feed into this process and guide us on how to do this efficiently. Thank you.
Oh, that was quite elaborate. I think it speaks to how maybe we need to approach the standardization. Dr. Judith, any addition to what Paul has said?
Yeah, sorry, can you clarify the question, please? Sorry.
Yeah, in trying to come up with standard protocols, it's easy to leave certain aspects of society out, people's diversity in terms of language, cultural norms. So what are the guiding principles in trying to formulate standard protocols?
Yeah, thank you so much. Yeah, I would also wish to tap into to what Paul has just shared. Maybe I'll share what is happening in terms of the implementation that are being done here in Tanzania. There are some codes in terms of ICT. It's called CPT, which has been recently developed. In long form, we call it common procedural terminologies. If East African countries maybe can sit and agree on this CPT, to have the same kind of CPT in every country that we use, the common CPT, I think we'll be able to come to overcome the challenges of languages, those are the ones which we are saying, because we have a lot of languages. If we can say we start counting the language that we have just in Uganda, just in Kenya, and other countries in East Africa, there are so many. Therefore, if we could have a unified CPT, I believe the standardization can help at large in terms of solving such kind of challenges. Yeah, thank you so much.
Oh, I don't know if Uganda has that yet. Maybe Paul can speak of if Uganda has any CPTs, but I'm sure he is.
For us, we've just recently developed it, and we are currently implementing it. So this is what I was saying. We should try to share our successes and challenges so that we can quickly adapt and move fast in terms of what we want to achieve.
Absolutely. Thank you so much. That's the takeaway. Maybe the attendees can also go out and see if we have any CPTs, or if anyone in the audience can relate to maybe what personally, I don't know if you have any CPTs in Uganda that can speak to that. Paul is at a higher level to comment on that. Let's hear from Stephen.
All right, thanks, Dr. Martin. I mean, I think for me, to answer your question, yes, there are three very important things we need to do. One, we need to foster innovation. Innovation comes from us tapping and exploiting our human resource. East Africa region has extremely smart young people. I think you go to any country, go to Uganda, Tanzania, Rwanda, Kenya, South Sudan, and all, you meet really innovative, entrepreneurial young people, really, really smart, doing all sorts of things, building all kinds of interesting digital health solutions and all that. So I think the governments and the other bodies and all, they need to foster that by putting some structure that actually promotes that innovation ecosystem. I think Uganda, Tanzania, Kenya, and Rwanda and others have innovation hubs, where these young people spend time and create really wonderful solutions. But where do they go? Most of the time they end up just on their laptops, and these guys move on. So we are not tapping into something that we have naturally, which is we have serious brain power. So that's one. Then secondly, I think innovation by itself and bring out siloed innovation solutions is not good enough at a country level. That needs to be translated into something that can significantly affect the enterprise, the ecosystem and the health system. So that's where government comes in. And so I think when that happens, then government needs to play its part and ensure that these innovations go through, like Paul mentioned, go through a process of translating them into solid evidence that can inform bigger investments. So that's where academia comes in, the collaborations and all, because evidence is what drives economic development. You can't just do things haphazardly, even in medicine, technology, and all that. So then innovations feed into evidence, and there's a whole rigorous process of creating evidence and new knowledge. Then once that is done, then government within its setup helps ensure that those are implemented as a standard practice, and therefore you create standards that way. So everyone is involved, and then government plays its role in terms of regulation, ensuring that what's come through, and it's come through the rigor of innovation, evidence-based, and now it's being practiced, it's also regulated. So that's what I would say, Dr. Martin. Thank you.
All right, thank you so much. I will hand over to Flavia. Thank you for everything, for your sharing. Over to you, Flavia. Kindly unmute. I think we're getting some technical challenges, but on behalf of the moderator, Flavia and Dr. Ruth, I would like to thank our panelists for making it on time and really engaging with the audience in this critical area of discussion. It has been well represented because it's an East African issue. We try to make sure we get representation from key stakeholders across borders, and I would like to thank Stephen, who has joined in all the way from Kenya, Dr. Lego joining in from Tanzania, and Paul Mbaka joining in from Uganda, representing the Ministry of Health. And from the discussion going on, you can see that Paul and the rest of his colleagues are really keen on making sure that this, what Paul is calling cross-pollination, happens across the borders. And to that, I would like to thank all our panelists for making time, having such deep conversations, and being very practical about the outcomes of what they intend to get from the work that they're doing to enable health systems across the region. I have posted links to our breakout sessions. You will see that we are trying to move in a sequence that now that there are quite a number of themes that have been coming up, equity, inclusion, design thinking, how do we think of policy, how do we think of solutions, how do we think of processes? And there's an issue with regard to climate change and how that speaks of healthcare. Currently, there's an ongoing discussion, the COP26, where all the global leaders are trying to come up with all these fast-track solutions to implement with regard to curbing climate change. climate plays a very huge role in healthcare. And so we have curated breakout sessions that will include gender and inclusivity, climate change, and also design thinking in healthcare. And we are going to leave this session on. We shall just mute such that, because we're going to take a 30 minutes break to refresh, so that we join these very engaging discussions at exactly 11. So to our dear panelists and attendees, kindly look through the chat. You will see that I have posted the respective links and the session titles. We have healthcare innovations addressing equity and inclusion, a very engaging discussion going to be moderated by Dr. Hope McLean. Technology advancements for global health, Dr. Charles Bate, who's doing quite incredible work in climate change and healthcare, will be moderating that session. We shall be having presentations all the way from Burkina Faso and the rest of Africa. We shall be having design thinking that will be led by Timo, and he will be engaging people who are working in the space of having design thinking at the core of the work that they do in healthcare and other services. So we encourage our attendees to join these links, these sessions at exactly 11. That's about 24 minutes from now, so that we can engage more into how to translate what we've been discussing in the previous, yesterday and this session, into more practice going forward. So thank you so much. We shall let this link be open till 11, such that our attendees, after their break, they can come and have access to these links and then join the respective sessions. Thank you so much, and see you at the breakout sessions. And to our panelists for this session, thank you so much.
Thank you all. Bye-bye.
Yeah, thank you so much.
Hello. I request our attendees to kindly join the respective breakout sessions. If you can check in the chat section, I put the different links. Kindly join one of the breakout sessions that you would like. We have gender and inclusivity and inclusion. We have climate change, and we have design thinking. So kindly select one of those, and then we shall be back into the plenary after the breakout sessions. Thank you so much. A kind reminder to us who are still on this link, kindly check through the respective sessions, breakout sessions that I've included links to, and kindly join one of the breakout sessions. We shall be back here at 12:30 to join the plenary. But for now, we are going into breakout sessions. Please check in the chat. When you go to the chat, you will see that we have shared links to the breakout sessions. Please choose one of the breakouts and join the rest of the engaging moderators who are going to be taking us through the other breakout sessions, please. Thank you. So check the chats, please. The breakout links have been shared up. Just kindly scroll up. You will see in the chat. Just keep scrolling. You will see You will see that up there's one on healthcare innovations addressing equity and inclusion. Then we have climate change and design thinking. Dr. Lake, let me confirm, but I think it's the right link that you joined. Let me reshare the links. I have reshared the links, please. If you can look in the chat, kindly go to one of the breakout sessions. We shall be back here right after the breakout. Thank you.
Recording in progress.
In management science, but I worked more with innovators and on projects that are health related. I'm happy to be here to speak about design thinking. Thank you.
Thank you, Nariat. And then last but not least, Joanita.
Hi, thanks, Timo. My name is
Twali tukosebwa nnyo mu bigambo by'entambula okuva e Buwunge okugenda ku ddwaliro e Bufumira. Nga tutambula oluusi nga tuyita mu mazzi naye ng'olw'embeera y'ensimbi nga bitukaluubirizaamu kuba ate okutambula okuva e Buwunge okutuuka e Bufumira ziri mayiro 7 naye nga tufunamu okunyigirizibwa kubanga embeera y'obudde enkuba etonnye entambula egaanye naye kati tuli basanyufu nnyo ku lw'enkulaakulana gye twafuna mu kitundu kyaffe okututuusiza eddagala ku kyalo kwe tuli. Eddagala tulifunira mu budde batuwa emyezi 3 abasawo baffe batukozeemu omulimu mulungi batubudaabuda batuwagadde ate batuzizzaamu amaanyi. Bannange mwebale nnyo mwebalire ddala. nnyo mu bigambo by'entambula okuva e Buwunge okugenda ku ddwaliro e Bufumira. Nga tutambula oluusi nga tuyita mu mazzi naye ng'olw'embeera y'ensimbi nga bitukaluubirizaamu kuba ate okutambula okuva e Buwunge okutuuka e Bufumira ziri mayiro 7 naye nga tufunamu okunyigirizibwa kubanga embeera y'obudde enkuba etonnye entambula egaanye naye kati tuli basanyufu nnyo ku lw'enkulaakulana gye twafuna mu kitundu kyaffe okututuusiza eddagala ku kyalo kwe tuli. Eddagala tulifunira mu budde batuwa emyezi 3 abasawo baffe batukozeemu omulimu mulungi batubudaabuda batuwagadde ate batuzizzaamu amaanyi. Bannange mwebale nnyo mwebalire ddala.
So virtual reality is a computing technology, and all it is about really is that you're using computers or computational capabilities to simulate a reality. And that is why it's called a virtual reality, because it's just being simulated. And the idea around that is that once a reality is simulated, it means that you don't need to buy a lot of physical things you would have needed to actually carry it out, because you're just creating an e-version of that reality. And you're using virtual reality competencies to do that. But to do that, you need the right platforms, you need the right technology, you need the right skills. And that is what this project was about.
So we learned that, and as we speak, we have quite a number of collaborations, mainly with the National Institutes of Health. The National Institutes of Health is 3D Exchange Lab. So as IDI, the next steps, or what we are going to be doing, is that like we believe in capacity building, and training is one of our core activities. So we are going to be implementing virtual reality trainings at this center, and as of now, we are actually trying to create the courses and the content to create the next generation of the experts into this field.
The content that we developed has an inbuilt assessment component. So as the student is learning using the virtual reality developed content, they go on being assessed in terms of whether they are doing the right thing or not. And the system is in such a way that you cannot move to the next step until you have mastered a particular step.
So we are using the latest Oculus Quest that has hand tracking. So it tracks your hand, and what she's doing right now, she's trying to project what she's seeing for us on this big screen, such that we are able to have a look at what is happening in the environment.
We had the technology configured in a way that it needed to be proficient. We had programmed artifacts. We developed a hybrid environment, a hybrid platform that involved what they call 360-degree videos being merged with virtual reality and being merged with static images. So that hybrid platform was something that we generated and used it here. And then we had to optimize it for sound, optimize it for video, and all these were parts of the development process. And so we're able to then generate these interactive, immersive artifacts that were then used to apply in a medical context.
Virtual reality really can help you to be able to reach out to so many learners and at a minimum, at a reduced cost, because as you have seen so far, we didn't need to buy, gloves, hand washing facilities, the personal protective equipment, which are very expensive. But we're able to teach our learners using virtual reality content. We believe that by the time we move them from the virtual reality learning environment to go to the real patient environment, it won't take us too much of our effort to get them to adapt to be able to do the right thing.
The World Health Organization, WHO, has made recommendations for the adoption of digital systems to promote efficiency in HIV programming. The Ugandan Ministry of Health has adopted this recommendation and in its 2018 guidelines recommends the use of informational technologies in the scale-up of antiretroviral therapy. WHO and the Ministry of Health have implemented Uganda EMR, OpenMRS, as a patient management system. However, the system is not web-based and there is no provision for inter-facility communication. Secondly, the Uganda EMR software is a desktop application and cannot run on mobile smartphones. This makes it impossible for real-time data entry at drug distribution points. ArtAccess is a web-based application that links patient health information such as viral loads, their HIV treatment regimen, and streamlines art delivery to private pharmacies in Kampala.
It was a little bit hard because of the number of clients are too many. So whenever you do come, you have to take almost the whole day. And when it comes to going to pick the drugs, the line was always very long.
The rapid scale-up of antiretroviral therapy has been challenging in very many countries, including Uganda. It has led to overcrowding in facilities. There's now so many patients accessing antiretroviral therapy. And the Ministry of Health, together with WHO, advised countries to implement differentiated service delivery models. IDI worked with private pharmacies to be ART delivery points for health facilities.
This project, ArtAccess, seeks to address the barriers of private pharmacy engagement in care and catalyze the operationalization of differentiated art delivery. However, there is limited data on the impact of integrated patient management systems on patient experience with care and treatment outcomes. The cost effectiveness of these systems has not been described.
Ideally, we need a patient who is stable on ART And those clients are supposed to be having a suppressed viral load to start with. And also, we need a patient who's taking their medicine very well. They have a good adherence of 95 and above %.
AtAccess is a tool that tracks clients on community pharmacy program. And these are basically 2 pharmacies for Kawala Health Center, 3, and that is Shubi Pharmacy, and then Seda's Pharmacy that is stationed in Nankulabe. Ideally, they help the clients have easy access to their drugs, and they don't have to spend a lot of time at the facility like it was before.
Because we have almost 1,000 plus clients, so we use it to monitor them, their complaints, the challenges they are facing, and even getting their medication.
If you have patients like in the next 2 weeks, you are able to know the number you have. As long as you click there in the data, in the access tool system, you're able to know that you have like 50 clients for the next 2 weeks. Then you order the drugs accordingly.
It has helped me so well because as a teacher, you know, our schedules are always very tight. You need to be there at school. So this one has helped me. I can go there within 5 minutes. I'm served, I get my drugs, and I go and attend to my students.
The impact of this pilot will be to cement the use of mHealth technologies as a system strengthening opportunity, allowing policymakers, HIV care implementers such as NGOs, funding bodies, and commercial companies to creatively think of technologies they can employ. This care cascade is of vital public health importance. Starting on ART and reaching an undetectable HIV viral load through good adherence reduces mortality and onward transmission of HIV.
So our plan is to scale up to all private pharmacies that are enrolled, that are part of the greater IDI KHP project. And our ultimate vision for this program is to allow every patient in this country to access antiretroviral therapy at any health facility they go to.
Twali tukosebwa nnyo mu bigambo by'entambula okuva e Buwunge okugenda ku ddwaliro e Bufumira. Nga tutambula oluusi nga tuyita mu mazzi naye ng'olw'embeera y'ensimbi nga bitukaluubirizaamu kuba ate okutambula okuva e Buwunge okutuuka e Bufumira ziri mayiro 7 naye nga tufunamu okunyigirizibwa kubanga embeera y'obudde enkuba etonnye entambula egaanye naye kati tuli basanyufu nnyo ku lw'enkulaakulana gye twafuna mu kitundu kyaffe okututuusiza eddagala ku kyalo kwe tuli. Tulifunira mu budde batuwa emyezi 3 abasawo baffe batukozeemu omulimu mulungi batubudaabuda batuwagadde ate batuzizzaamu amaanyi. Bannange mwebale nnyo mwebalire ddala.
So virtual reality is a computing technology, and all it is about really is that you're using computers or computational capabilities to simulate a reality. And that is why it's called a virtual reality, because it's just being simulated. And the idea around that is that once a reality is simulated, it means that you don't need to buy a lot of physical things you would have needed to actually carry it out, because you're just creating an e-version of that reality. And you're using virtual reality competencies to do that. But to do that, you need the right platforms, you need the right technology, you need the right skills. And that is what this project was about.
So we learned that, and as we speak, we have quite a number of collaborations, mainly with the National Institutes of Health. The National Institutes of Health is 3D Exchange Lab. So as IDI, the next steps, or what we are going to be doing, is that we believe in capacity building, and training is one of our core activities. So we are going to be implementing virtual reality trainings at this center, and as of now, we are actually trying to create the courses and the content to create the next generation of the experts into this field.
The content that we developed has an inbuilt assessment component. So, as the student is learning using the virtual reality developed content, they go on being assessed in terms of whether they are doing the right thing or not. And the system is in such a way that you cannot move to the next step until you have mastered a particular step.
So we are using the latest Oculus Quest that has hand tracking. So it tracks your hand, and what she's doing right now, she's trying to project what she's seeing for us on this big screen, such that we are able to have a look at what is happening in the environment.
We had the technology configured in a way that it needed to be proficient. We had programmed artifacts. We developed a hybrid environment, a hybrid platform that involved what they call 360-degree videos being merged with virtual reality and being merged with static images. So that hybrid platform was something that we generated and used it here. And then we had to optimize it for sound, optimize it for video, and all these were parts of the development process. And so we're able to then generate these interactive, immersive artifacts that were then used to apply in a medical context.
Virtual reality really can help you to be able to reach out to so many learners, and at a reduced cost, because as you have seen so far, we didn't need to buy, gloves, hand washing facilities, the personal protective equipment, which are very expensive. But we're able to teach our learners using virtual reality content. We believe that by the time we move them from the virtual reality learning environment to go to the real patient environment, it won't take us too much of our effort to get them to adapt to be able to do the right thing.
The World Health Organization, WHO, has made recommendations for the adoption of digital systems to promote efficiency in HIV programming. The Ugandan Ministry of Health has adopted this recommendation and in its 2018 guidelines recommends the use of informational technologies in the scale-up of antiretroviral therapy. WHO and the Ministry of Health have implemented Uganda EMR, OpenMRS, as a patient management system. However, the system is not web-based and there is no provision for inter-facility communication. Secondly,
The Uganda EMR software is a desktop application and cannot run on mobile smartphones. This makes it impossible for real-time data entry at drug distribution points. ArtAccess is a web-based application that links patient health information such as viral loads, their HIV treatment regimen, and streamlines art delivery to private pharmacies in Kampala.
It was a little bit hard because of the number of clients are too many. So whenever you do come, you have to take almost the whole day. And when it comes to going to pick the drugs, the line was always very long.
The rapid scale-up of antiretroviral therapy has been challenging in very many countries, including Uganda. It has led to overcrowding in facilities. There's now so many patients accessing antiretroviral therapy. And the Ministry of Health, together with WHO, advised countries to implement differentiated service delivery models. IDI worked with private pharmacies to be ART delivery points for health facilities.
This project, ArtAccess, seeks to address the barriers of private pharmacy engagement in care and catalyze the operationalization of differentiated art delivery. However, there is limited data on the impact of integrated patient management systems on patient experience with care and treatment outcomes. The cost-effectiveness of these systems has not been described.
Ideally, we need a patient who is stable on ART, and those clients are supposed to be having a suppressed viral load to start with. And also, we need a patient who is taking their medicine very well. They have a good adherence of 95 and above %.
ArtAccess is a tool that tracks clients on community pharmacy program, and these are basically 2 pharmacies for Kawala Health Center, 3, and that is Shubi Pharmacy, and then Cedars Pharmacy that is stationed in Nankulabe. Ideally, they help the clients have easy access to their drugs, and they don't have to spend a lot of time at the facility like it was before.
Because we have almost 1,000 plus clients, so we use it to monitor them, their complaints, the challenges they are facing, and even getting their medication.
If you have patients like in the next 2 weeks, you are able to know the number you have as long as you click there in the data in the access tool system. You're able to know that you have like 50 clients for the next 2 weeks. Then you order the drugs accordingly.
It has helped me so well because as a teacher, you know, our schedules are always very tight. You need to be there at school. So this one has helped me. I can go there within 5 minutes. I'm served, I get my drugs, and I go and attend to my students.
The impact of this pilot will be to cement the use of mHealth technologies as a system-strengthening opportunity, allowing policymakers, HIV care implementers such as NGOs, funding bodies, and commercial companies to creatively think of technologies they can employ. This care cascade is of vital public health importance. Starting on ART and reaching an undetectable HIV viral load through good adherence reduces mortality and onward transmission of HIV.
So our plan is to scale up to all private pharmacies that are enrolled, that are part of the greater IDI KHP project. And our ultimate vision for this program is to allow every patient in this country to access antiretroviral therapy at any health facility they go to.
Twali tukosebwa nnyo mu bigambo by'entambula okuva e Buwunge okugenda ku ddwaliro e Bufumira. Nga tutambula oluusi nga tuyita mu mazzi naye ng'olw'embeera y'ensimbi nga bitukaluubirizaamu kuba ate okutambula okuva e Buwunge okutuuka e Bufumira ziri mayiro 7 naye nga tufunamukko okunyigirizibwa kubanga embeera y'obudde enkuba etonnye entambula egaanye naye kati tuli basanyufu nnyo ku lw'enkulaakulana gye twafuna mu kitundu kyaffe okututuusiza eddagala ku kyalo kwe tuli. tulifunira mu budde batuwa emyezi 3. Abasawo baffe batukozeemu omulimu mulungi, batubudaabuda, batuwagadde ate batuzizzaamu amaanyi. Bannange mwebale nnyo, mwebalire ddala.
So virtual reality is a computing technology, and all it is about really is that you're using computers or computational capabilities to simulate a reality. And that is why it's called a virtual reality, because it's just being simulated. And the idea around that is that once a reality is simulated, it means that you don't need to buy a lot of physical things you would have needed to actually carry it out, because you're just creating an e-version of that reality. And you're using virtual reality competencies to do that. But to do that, you need the right platforms, you need the right technology, you need the right skills. And that is what this project was about.
So we learned that, and as we speak, we have quite a number of collaborations, mainly with the National Institutes of Health. The National Institutes of Health is 3D Exchange Lab. So as IDI, the next steps, or what we are going to be doing, is that we believe in capacity building, and training is one of our core activities. So we are going to be implementing virtual reality trainings at this center, and as of now, we are actually trying to create the courses and the content to create the next generation of the experts into this field.
The content that we developed has an inbuilt assessment component. So, as the student is learning using the virtual reality developed content, they go on being assessed in terms of whether they are doing the right thing or not. And the system is in such a way that you cannot move to the next step until you have mastered a particular step.
So we are using the latest Oculus Quest that has hand tracking. So it tracks your hand, and what she's doing right now, she's trying to project what she's seeing for us on this big screen, such that we are able to have a look at what is happening in the environment.
We had the technology configured in a way that it needed to be proficient. We had programmed artifacts. We developed a hybrid environment, a hybrid platform that involved what they call 360-degree videos being merged with virtual reality and being merged with static images. So that hybrid platform was something that we generated and used it here. And then we had to optimize it for sound, optimize it for video, and all these were parts of the development process. And so we're able to then generate these interactive, immersive artifacts that were then used to apply in a medical context.
Virtual reality really can help you to be able to reach out to so many learners, and at a reduced cost, because as you have seen so far, we didn't need to buy, gloves, hand washing facilities, the personal protective equipment, which are very expensive. But we're able to teach our learners using virtual reality content. We believe that by the time we move them from the virtual reality learning environment to go to the real patient environment, it won't take us too much of our effort to get them to adapt to be able to do the right thing.
The World Health Organization, WHO, has made recommendations for the adoption of digital systems to promote efficiency in HIV programming. The Ugandan Ministry of Health has adopted this recommendation, and in its 2018 guidelines recommends the use of informational technologies in the scale-up of antiretroviral therapy. WHO and the Ministry of Health have implemented Uganda EMR, OpenMRS, as a patient management system. However, the system is not web-based, and there is no provision for inter-facility communication. Secondly, The Uganda EMR software is a desktop application and cannot run on mobile smartphones. This makes it impossible for real-time data entry at drug distribution points. ArtAccess is a web-based application that links patient health information such as viral loads, their HIV treatment regimen, and streamlines art delivery to private pharmacies in Kampala.
It was a little bit hard because of the number of clients are too many. So whenever you do come, you have to take almost the whole day. And when it comes to going to pick the drugs, the line was always very long.
The rapid scale-up of antiretroviral therapy has been challenging in very many countries, including Uganda. It has led to overcrowding in facilities. There's now so many patients accessing antiretroviral therapy. And the Ministry of Health, together with WHO, advised countries to implement differentiated service delivery models. IDI worked with private pharmacies to be ART delivery points for health facilities.
This project, ArtAccess, seeks to address the barriers of private pharmacy engagement in care and catalyze the operationalization of differentiated art delivery. However, there is limited data on the impact of integrated patient management systems on patient experience with care and treatment outcomes. The cost-effectiveness of these systems has not been described.
Ideally, we need a patient who is stable on ART, and those clients are supposed to be having a suppressed viral load to start with. And also, we need a patient who's taking their medicine very well. They have a good adherence of 95% and above.
ArtAccess is a tool that tracks clients on community pharmacy program. And these are basically 2 pharmacies for Kawala Health Center, 3, and that is Shubi Pharmacy, and then Seda's Pharmacy that is stationed in Nankulabe. Ideally, they help the clients have easy access to their drugs, and they don't have to spend a lot of time at the facility like it was before.
Because we have almost 1,000 plus clients, so we use it to monitor them, their complaints, the challenges they are facing, and even getting their medication.
If you have patients like in the next 2 weeks, you are able to know the number you have. As long as you click there in the in the access tool system, you're able to know that you have like 50 clients for the next 2 weeks. Then you order the drugs accordingly.
It has helped me so well because as a teacher, you know, our schedules are always very tight. You need to be there at school. So this one has helped me. I can go there within 5 minutes. I'm served, I get my drugs, and I go and attend to my students.
The impact of this pilot will be to cement the use of mHealth technologies as a system strengthening opportunity, allowing policymakers, HIV care implementers such as NGOs, funding bodies, and commercial companies to creatively think of technologies they can employ. This care cascade is of vital public health importance. Starting on ART and reaching an undetectable HIV viral load through good adherence reduces mortality and onward transmission of HIV.
So our plan is to scale up to all private pharmacies that are enrolled, that are part of the greater IDI KHP project. And our ultimate vision for this program is to allow every patient in this country to access antiretroviral therapy at any health facility they go to.
Twali tukosebwa nnyo mu bigambo by'entambula okuva e Buwunge okugenda ku ddwaliro e Bufumira. Nga tutambula oluusi nga tuyita mu mazzi naye ng'olw'embeera y'ensimbi nga bitukaluubirizaamu kuba ate okutambula okuva e Buwunge okutuuka e Bufumira ziri mayiro 7 naye nga tufunamu okunyigirizibwa kubanga embeera y'obudde enkuba etonnye entambula egaanye naye kati tuli basanyufu nnyo ku lw'enkulaakulana gye twafuna mu kitundu kyaffe okututuusiza eddagala ku kyalo kwe tuli. tufunira mu budde batuwa emyezi 3 abasawo baffe batukozeemu omulimu mulungi batubudaabuda batuwagadde ate batuzizzaamu amaanyi bannange mwebale nnyo mwebalire ddala
Hello, everyone. Welcome back from those very engaging and exciting breakout sessions that we had. It's been 2 days and we are getting to more interesting conversations. There's an area that we all shy away from talking about when it comes to our work, our personal life. But this has been, it has gotten worse in the pandemic because you realize that the issues to do with mental health are ignored. They are seen as a taboo to be talked about. When the pandemic hit, everyone was equally affected, from the healthcare workers, families, people losing jobs, people losing relatives. So mental health has really stood out as a key aspect that we need to be open about, talk about it. Employers, together with employees, need to be open about the fact that mental health is critical in the way that we work, and really nothing impacted people's mental health than COVID. And from the different facets that you would want to look at this, it's only that we need to be very open to talk about it. So we thought that this is a conversation we need to have at this conference. We need to start creating this awareness, but then also be intentional and take action on the things that we have realized since we are learning from the pandemic on how to do different. And so we have Jackie, who works with the Academy. She's a social scientist. She has been very instrumental in helping her own colleagues to approach the conversation, mental health and work, but going beyond work, our family is coping with the different stresses. And now with the pandemic, people losing jobs, the uncertainty, the anxiety that still looms around and needs to be addressed. And to that, the most appropriate way that we could have this conversation is by having people who are comfortable in this space to talk about these issues and also raise awareness and create a sense of responsibility amongst us to take our mental health very, very seriously. Jackie will be joined by Elizabeth Kakoza, And we have Leona Buhenzire, and she will be moderating this session. I'm not sure if Liz Kakoza has managed to join. She's been having some technical issues. She should be able to join us shortly. So Jackie, maybe giving a background to what mental health is and why we as the Academy, we thought that at the end of all the different discussions where we talk about work, innovations, why was it critical that we talk about mental health at this conference? Because it might seem like it's not related to anything to do with innovation, but it's a very critical conversation, and you've been key in making sure that we are intentional in having this discussion before we close the conference. So over to you, Jackie, and the panelists. Thank you.
Thank you, Martin, and I welcome everyone to this session on the mental health clinic. Like you said, I'm going to be doing this with Liz. Unfortunately, she's still finding it hard to join, but I'm glad that two of the panelists are here and you're welcome to this session. Martin already introduced me. I'm Jackie Lydia Semata. I'm a psychologist and a social scientist at the Academy for Health Innovations, Uganda. So, and to start with, I thank you so much for having this incorporated into this conference. Like you said, it may be very, very funny, or people may not understand why we are having mental health at a health innovations conference, but it is some kind of awareness, and it is something that we really need, even at our workplaces, even as we go about the things that we do. It is one of the most important things, but yet it's often the least prioritized among the health conditions. So yes, and given that we've been having the COVID-19, we've also had a surge or high numbers of people that are struggling with mental health issues, but then some workplaces wouldn't recognize, or getting help has not been easy, especially in a country like Uganda. We have diseases, we have a lot of ignorance around. We take mental health as a luxury, yet it is something that we really need to talk about. So thank you so much, Martin. Our theme will be mental health in an equal world, unpacking mental health in a post-COVID world with inequality, under the conference theme, collaborate to transform. What lessons have we learned from the pandemic? I'll say something about COVID and mental health, then we can kick off with the objectives that we have set out for us to share. So the COVID-19 pandemic brought with it unprecedented mental health challenges for the general population. And the second wave didn't leave our country in peace. With many dead, we even had double digits dying in a single day. So this led to very many mental issues for the population, those who suffered from it, those who saw people suffer from it. So it became a little hard. And when we had the second wave, we had the government put in very stringent lockdown measures. For curbing the COVID-19, it was very easy. But then when it came to mental issues, we had many of the people having challenges mentally. Some countries like England also noted mental health challenges. And for them, it was mostly anxiety and post-traumatic stress disorder. When it came to Uganda, we also had an increase in hospital admissions. Here we use Butabika because it's the referral hospital that we have. And mostly it was on alcohol use or abuse and anxiety. So that's where most of the mental issues were coming from. So, excuse me. So this is why we really need to talk about this and see how we can curb, how we
we can know how we can help people, how we can put mental health out there. So as we tackle these challenges under this year's global theme of mental health in an equal world, we would like to shine a light on mental health issues that are predominant amongst the pandemic and how we can bring awareness to them and build resilience among the communities. Now, we are going to have a very interesting session, hopefully, and we'll do questions with the panelists that will be introducing shortly. But at the end of the day, the objectives that we would like to answer are education as on the importance of mental health, then a brief discussion, our understanding of the key mental health issues that have become prevalent during the pandemic, then lessons that we've learned from the pandemic, an introduction to self-care tools, and lastly, resources shared post-session. So I welcome Leona and Patricia. Oh, sorry.
Yes.
Liz, you're welcome. Liz is the founder and the team lead for MindLab. Finally, she's on. I'm glad you're on here. So I welcome you to this session as one of the moderators, and I hand over to you to introduce the panelists. Thank you.
I apologize for the delay in joining the session. I've had a few internet challenges, which is not new in the context we live in. My name is Liz Kakoza. I am the founder of MindLab, which is a non-profit, which is a startup that aims to democratize access to mental health care in Uganda. This panel or this conference and this session comes at such a critical time in our history. Not just, based on the pandemic, not just based on the COVID-19 pandemic, but we are starting to see the rise of a new pandemic, which is mental ill health. So this session is very critical as it shines a light, not just on this year's theme, which is mental health in an unequal world, but also understanding, collaborating to transform, understanding how innovation and technology can be leveraged to address mental health issues, but also dig deep into mental health issues witnessed or experienced primarily by innovators and people in the innovation space. I'm going to share with you my screen real quick as we get into the rest of the session. Just be patient with me. Technology seems to be failing me today, but we will get there.
Are you able to share, Liz? Can you?
Yes, I am. Just give me a second. So as we dig into better understanding, the topic of the day, Jackie got into all of this and, what we shall be discussing going forward. But I would just like to ask you, all of you attending the session today, to use your chat window and tell us, how are you feeling today? Because as we get into the topic of understanding, mental health, of digging deep into mental health, I believe it's important for us to check in with ourselves. So please take a minute, take a moment and use the chat window and tell us, are you feeling anxious, happy? What has made your day, exciting? Yeah, please share with us as we proceed. So I like this quote by Aristotle. It says, no genius has ever existed without a touch of madness. Many times when we talk about, entrepreneurship, when we talk about innovation, many innovators, entrepreneurs are subject to mental ill health, right? And they're misperceived by society and those around them. This quote is very personal to me, right? Because it's something I've heard because of my lived experience with mental health. It's something that I've come to associate with closely, but then also understanding that wherever an entrepreneur lives, wherever an innovator lives, it doesn't matter if they are in somewhere in Silicon Valley, this applies to them. So I would like us to look at to ask ourselves about the genius of madness. Is it just coincidence that the most brilliant minds are sometimes the ones that struggle the most with mental health challenges? What can we do about it? Sorry, I have exited my presentation again. But we will proceed. We will just go ahead and proceed, right? Yeah, there we go. So I'd like to share some statistics as we go along regarding mental health and entrepreneurship. 49% of entrepreneurs surveyed are dealing with at least one mental health illness. This is, it could be ADHD, ADD, bipolar disorder, addiction, and depression and anxiety. And about 1/3 of entrepreneurs struggle with 2 or more of these illnesses. Again, this is research, this is data that has been proven and is, it's quite common. I mean, we encounter people in the spaces, in the innovative spaces that we work with that deal with many times ADHD, and that is why sometimes innovators are the most brilliant, because they're great at thinking on their feet. They want to execute one idea after another, etc. 72% of entrepreneurs and innovators are directly or indirectly affected by mental health issues. So on today's panel, I would like to introduce Patricia Caballo, who is a co-director at MindLab. Patricia is also a trained psychologist and is further pursuing master's in psychology in child psychology. She'll go on to tell us about herself. And then we also have Leona Buhenzire, who is a psychologist in Kampala. I'll give her an opportunity to also further tell us about herself. And then, of course, myself, Liz Kakoza, who will be moderating the rest of the session. So as we dive into the session, Patricia, do you mind starting us off and introducing yourself and what you do?
Okay, thank you, Liz. I hope you can all hear me.
Yes, we can.
Okay, great. My name is Patricia Caballo. I'm a psychologist and co-director at the MindLab. I am very passionate about mental health awareness, and I am currently pursuing a master's in family and child psychology. So in a nutshell, that's a little bit about me. Thank you.
Leona, are you ready to introduce yourself?
Yes, I am. Hi, everybody. My name is Leona Buhenzire. I am a clinical psychologist with Mental Health Support Systems Uganda. I've been in practice for about 14 years this year. I'm very passionate about mental health. And I think that this period has offered us a unique insight into, offered others who are not in the mental health world, a unique insight into mental health and self-care and whatnot. And I'm glad about that. But yeah, that's a simple, quick introduction on myself.
Okay. Thank you for the introduction, Patricia and Leona. And I'm excited about unpacking this theme with the both of you today. A quick disclaimer as we get deeper into the session. I would like to say this session is not meant as a substitute for a professional consult or session with a mental health professional. If you identify with anything mentioned during this session, please schedule a consultation with either with your healthcare provider, either a psychologist, a psychiatrist, counselor, to discuss what you or your loved one may be going through. So in mental health, we do not believe in self-diagnosis, yet yes, it is important to remain alert and aware of what may be going on with you, but please reach out to a trained healthcare professional. So I'll start with you, Leona. The term mental health has received some attention over the past 17, 18 months of the pandemic. How would you define mental health, especially given our current context? How has the definition changed based on this context? I'll throw this question to both of you because you have had different experiences in the work that you do, in the patients that you see, etc.
How has the definition of mental health changed in the face of the pandemic?
Yes.
Well, I think it has changed from the general assumption that mental health is madness to that it's just specific to people with psychosis, psychotic disorders, to people actually understanding what mental hygiene is and the importance of coping mechanisms and self-care and all of that. So I think people have got a better and a deeper understanding of mental health today.
Thank you, Leona. Patricia, how has the definition of mental health changed for you amidst the pandemic?
Okay, thank you, Liz. Much like Leona has shared, I think we have a new appreciation for mental health. At the beginning of the lockdown, March 2020, yes, we saw a lot of people coming in with anxiety, with depression, and we'll get into these terms later. But people wanted to understand how their thoughts have now seeped into their physical bodies and how their thoughts have changed their moods, their behavior, and so on and so forth. So I think as a nation, we have a new understanding and a new appreciation for mental health and what it contributes to our general physical health.
I like that you both shared, a similar perspective on how there's more awareness around mental health. There's a general acceptance that's coming through regarding mental health at this point in time. However, as we get into the discussion, I would like us to dig deeper into our preparedness. How prepared are we to deal with the overwhelming numbers that will be a result of this awareness. So the last lockdown presented a 500% increase in hospital admissions for mental health disorders, ranging from anxiety to alcohol abuse disorder. And the World Health Organization has gone on to further report a 200% increase in suicides globally as a result of the pandemic. As experts in your field, what are the most common mental illnesses that have been reported and diagnosed during this time? What have you seen majorly diagnosed during this time. Would you agree with the statement that, suicides have gone up as well?
Definitely. Suicide. First of all, the mental health budget is not even 1% of the general health budget, which has increased because of COVID. And yet still the mental health budget is still not being given. It's not a priority still. So has suicide increased? By all means, it has increased. What coping mechanisms, what tools do people have? The beds I live in Butabika, not in the hospital, in the area. And I go to the hospital often and there's an overflow. There's no more beds for people. It's barely, people are barely getting by, and that's our national referral hospital. And so it's a crisis. There's a mental health crisis. According to World Health Organization, 2,000 Ugandans commit suicide per year. And that is those that are on record. You remember that because of stigma, most suicides are not on record. So
yeah.
if we've so far had 2,000 and I'm not sure, but 2,000 deaths due to COVID. And because of that, there's been a public, it's a crisis. We've had lockdowns, we've had, all sorts of measures have been put in place because of 2,000 people that have died over the last 2 years. But 2,000 people commit suicide every single year for years. That's not a new statistic,
Yeah.
So
I know. Yeah, sorry to cut you off. I know for sure there's a statistic that says we lose one person every 40 seconds to suicide. So yes, that number.
Uganda is rated, I think, the 11th with most suicides in the world.
Yes.
So,
yeah. Oh wow.
Yeah. So
yeah,
there's definitely been an increase during COVID.
And Patricia, what would you say are the most prevalent mental health issues that you have witnessed during this time? I know you worked in a hospital setting for a while you were here. So what have you experienced as the most common or the most prevalent issues at this point in time?
Okay, thank you, Liz. I'd also like to add to what Leona shared. So at the hospital, I was working at Nakasero Hospital, and we saw an influx of anxiety, depression, substance abuse clients. And just taking you back a bit to what Leona shared on the National Referral Hospital. To answer your question, Liz, you asked how prepared are we? I don't think we're very prepared. We're getting there. We have more information about mental health, but as a nation, are we prepared? I can't say we are because of there's different types of stigma. So for example, if only less than 1% of the healthcare budget goes to mental health, that's institutional stigma. So we are not prepared as a nation to tackle 2,000 suicides a year. We're not prepared to have enough beds at the National Referral Hospital. So we are getting there. We are getting more educated. So let's not lose hope in that sense. But we do have a lot to do, a lot to learn, and a lot to apply in our mental health care system in Uganda. I hope that answers the question, Liz. Thank you.
Yeah, thank you, Patricia. I know I've heard from health professionals that have worked, had to work through the pandemic, and hearing stories about mental health wards being converted to COVID wards. So that left a lot of people dealing with mental ill health at such a critical time with nowhere to go. So I hope, just like you've shared, just like the hope, that you've put across, I hope that, we will get there eventually in providing the resources that we all need to be able to address, the mental health pandemic. So kindly help us further understand some of these conditions. I mean, we hear things like depression, we hear anxiety, we hear substance abuse, we hear panic attacks. For the longest time, we have seen these on television, right? They seemed like, this far off problem that does not apply to us. But now, because of the pandemic, we're starting to, witness them. Our friends are dealing with them, our family members. Could you help us break some of them down? I know you could, amongst yourselves, you could, take one or two and help us properly understand them and, digest them to a level and contextualize them to a level that, an everyday person listening in can understand.
Okay, so we know that mental health is a state of well-being where every individual realizes his or her own potential, can cope with normal daily life stresses, work productively, and make a contribution to the community. That's according to the World Health Organization. So mental health exists on a spectrum, from good mental health and towards bad or ill mental health. So at any one point in your lifetime, you can find yourself anywhere on the spectrum. And the World Health Organization also tells us that 1 in 4 of us will suffer a mental health breakdown or illness or disorder at some point in our lives. So mental health illnesses and disorders are much more common than we think. So they range from anxiety to depression to substance abuse. And so when you're on that spectrum, we would like to say that if you're on the good side of it, you're healthy mentally. So how do you cope with daily life stresses? How do you cope with your stress at work, stress at home, stress in your social setting? How do you cope with unemployment? How do you cope with alcohol and drugs? How do you cope with stresses maybe with your children? In life, we'll all deal with some sort of stress at some point. So stress can contribute to your mental health, but there's so many other factors. So we have genetics. We've seen in twins, there's a 70% chance that if one twin has depression, the other twin will develop some sort of mental health disorder. We've also seen biochemistry, and I'll let Leona explain a little further on this. Chemical imbalances and hormonal imbalances in the brain. We've also seen environmental factors that affect our mental health. People that are brought up in war-torn zones, people that have experienced trauma, children that have gone through neglect and abuse. And lastly, personality. How are you innately? Are you naturally a pessimist? Are you more optimistic? We've seen that people with more pessimistic personalities are more susceptible to depression. So there's so many factors that go into one's mental health. So when describing mental health, some of these disorders, we were talking about the stigma earlier. Some of the ways we can stigmatize ourselves is using these disorders themselves. For example, using the word anxiety, which is an actual disorder, to describe maybe you feeling a little bit tense. So there's a difference between being anxious, and there's a difference between between being anxious and having an anxiety disorder, or there's a difference between weather changes and the weather being bipolar, as people may say. So some of these words and some of these, what we use to describe these illnesses can actually stigmatize us more. So maybe I'll let Leona take us through the definitions of these disorders.
See, the thing is, to give a definition of a diagnosis right here, I wouldn't want to, it's not that linear as it is in the DSM-5, right? For me to be able to diagnose, if anybody thinks they're struggling with depression or with anxiety or with addiction, it's imperative that you seek help. It's imperative that you go to a professional and get a diagnosis, because I might tell you, for example, generalized anxiety disorder, GAD, okay? You have to have excessive worry. That kind of checks out every single adult, right? But if I sit with you, I will probe and I'll find out what is the percentage of your waking hours do you worry? Is the worry accompanied by reassuring, seeking from others? Is it debilitating? Is it triggered? Do you worry even when there's no trigger for it? What environment do you live in? Is there anyone in your family that has struggled with anxiety? Tell me about your father. Tell me about your mother. Maybe you don't even know what anxiety is, but you've lived around it, you see. So to just give it a definition, I feel would not be satisfactory. I feel that if you might think you're having issues with, I would say for one, if you're failing to perform the activities that you usually perform, seek help. Seek help. If you're worrying more than usual and that worry is causing you to lose enjoyment in the things you've been enjoying, your enjoyments, and to, seek help. Seek help. If it's debilitating you in any way, seek help. If the things that used to give you pleasure do not, seek help. And that's not to say that you are clinically depressed. That's to say that you ought to find out.
Yes. To basically to do a check-in and see, I like to say visiting, say, a therapist or a psychiatrist. Sometimes we don't need to wait for the issue to escalate, but the same way you go for your routine dental checkup or your routine mammogram, or it's important to consider that. And I really like what Patricia said about self-stigmatization. I always like to say mental health, terms around mental health are not adjectives, right? So the weather can't be OCD, that fuels stigma. Or you can't say, oh my God, I'm so depressed because it rains today. No, that in itself fuels stigma. So because this is a health innovation conference, before we dig deep into how entrepreneurship and innovation can be leveraged to, address mental health issues, I want us to understand, and I want to ask the both of you, because you're both practicing psychologists, and you see, I'm sure in your practice, you've seen innovators, entrepreneurs, people that would consider, geniuses. What is it that drives them, or what are the, I wouldn't want to say issues, but what drives them towards negative mental health? Because studies have shown that, like I shared earlier, 72% of them will deal with a mental health issue. So help us understand, where does that come from, to affect that, their mental health in a negative manner?
Well, to affect your mental health, that's very general. First of all, it can literally be genes. You can have a susceptibility to it, right? It could be your environment. Maybe you live in an area with a lot of noise, maybe you live in a slum area. Maybe you live in an environment with a violent environment. Maybe you have trauma. Maybe there's abuse, some sort of abuse going on in your world. Mental, emotional abuse is as powerful as physical abuse. It's not to be underlooked. Maybe the pressure from work, pressure on adults is a lot, and they just keep piling stress and not coping, not dealing with it, because we are taught to just sweep things under the rug. And so it piles and piles until it's a full-blown beast that is depression. So what causes those negative, we live in an economy also that is not very progressive for many, for many entrepreneurs. That can be very frustrating, the feelings of failure, so yeah.
Most definitely, Leona, I really do agree with what you're saying. There's so many factors, like we mentioned earlier. But also what everyone, much like innovators or anyone really can go through, is burnout. So stress in the workplace can cause burnout. Stress at home can cause burnout. So burnout is basically a state of emotional, physical, and mental exhaustion. This is usually caused by excessive or prolonged stress and where someone is unable to meet their constant demands. And we know that for every $1 spent on mental health care, there's $4 gained in productivity. So employers, take note of this because your employees' mental health is very, very important. So if they burn out, they lose out, but also you too lose out. So much like Leona shared, there's so many factors, but the first one would be stress, which will lead to burnout, which could lead to many other mental health disorders. That's if there wasn't already a pre-existing mental health condition, or if someone wasn't already susceptible to a mental health condition.
Yeah, thank you for those insights, Patricia. I call myself a serial entrepreneur, and I know it's easy to, get lose yourself in this loop of entrepreneurship. Leona talked about, access to financing, just, finding people that believe in your vision, building a team, etc. All of these little elements of setting up, an enterprise, a business, etc. have such a negative, impact on our mental health. And we don't have programs like this, that are equipping entrepreneurs with the skills that they need to be able to navigate their own mental health. So this year's theme is mental health in an unequal world. We understand that the pandemic has widened the inequality gap. For example, we can see that the gap between the global north and the global south, as we try to achieve vaccine equity, has widened. We see that the widening of that gap. Down to the individual level, there seems to be increased inequality even in access to mental health care. Given your experience, your expertise, what tools can we employ, both from an entrepreneurial perspective? What innovations can we create or leverage as society to be able to ensure that there's equal access of mental health care for all?
How to ensure equal access to mental health care? Ensuring equal access, there's no such thing as equal access. You access what you can manage to access. Mental health care is generally more expensive than physical health care, which for reasons that I'm sure you're aware of. Let me give you an example. Right now, we are trying to establish a clinical psychology association, and that's because the government has refused for us to establish one. So everybody has to be registered under Counseling, Uganda Counselors Association, So the institutional stigma in itself does not allow, that means that a clinical psychologist is not rated. That's somebody who has spent 7 years in school in Makerere and Mulago and Butabika, right? They're still not rated on the government radar in paying salaries, right? So they're paid low salary. It's a low pay. So most people will either go into private practice or they will take up other professions, right? Butabika Hospital only has one head clinical psychologist, right? That's the National Referral Hospital for Mental Health. So accessibility to mental health, can it be equal? I don't think that it's in our power. I think the people who have the power, we're trying to get there. I'm part of the team that is getting to register us as clinical psychologists. It's basically to get the government to recognize mental health and literally rate us.
Yeah.
Right? Right. So if from the government you're not rated, that means that you're not regulated. So first of all, we would have to be regulated for us to be affordable, because I can open my own practice and charge you 500,000 per hour. You see, there's no regulation. There's no criteria that I'm following. You see? So perhaps one way to do that would be to join this call that we're trying to put to the Ministry of Health, to be able to regulate us as professionals.
Yeah, I totally agree with you, because in so doing, that lack of regulation, but also in the failure of our healthcare system to incorporate mental health care as a key component of universal healthcare, it has widened that inequality gap. Patricia, how would you say that, or what ideas do you have that while regulation is still a problem, while recognition from key players in the health sector remains a challenge, what community solutions can we create? Because innovation isn't necessarily about technology all the time, and I think that's where we get it wrong. But what solutions within the community can we employ? Can we create to ensure that there's a certain level, a basic level of psychosocial support within the community?
I think the main issue at the moment, aside from the institutional stigma, is a stigma within the communities. There's a lot of myths and misconceptions around mental health, and that's the main hindrance when it comes to bringing in a loved one to a hospital. People do not know what to do when their loved one or themselves are going through a tough time, or they're not, their functionality is down, their productivity is down, their mood is down. People don't know what to do. In many communities, mental health disorders are still looked at as a cause because of witchcraft or some other, I don't know, voodoo or something like that. So there's a lot of myths and misconceptions around mental health. I think the first point would be to educate and re-educate some people, our communities. It would be really, really nice, ideal to have at the community, at the grassroots level, at a primary school, at a secondary school, even at university, to have these mental health camps within those facilities. There's been reports of increased abuse, especially during this COVID period. Before, children, their safe haven was going to school if they were being abused at home. But now they go to school, and then that's happening there as well. Where do they go if they need support, right? Where does a teenage girl go if she's being abused by a relative at home, but also being abused by her teacher at school? We need these support systems at the grassroots level, and we need to continue having. That's why I'm really happy to be on such a call, to have these conversations, to normalize these conversations around mental health, and that, I believe, will help us destigmatize mental health, destigmatize ourselves, destigmatize our loved ones, and hopefully the government as well. Yeah, thank you.
Thanks for sharing that, Patricia. Just like the most interesting thing is, and people from IDI and people in the healthcare space will tell us we have what we call public health educators, right? But I think within the curriculum or the programming that is built around them, there's a very minimal element of mental health care. And again, I like to say, when the HIV pandemic happened, many years ago, many of us were children and we just saw, relatives die, or we heard about this. what happened was there was a massive, public health campaign. And that is why, for so many years, we were able to bring, to lower our infection rates and to lower HIV infection rates across the country. And we were a model nation in that regard. So I believe that it is interventions such as these that, will help us ultimately be able to, address even mental health challenges as they come along as a result of the pandemic, but because they've already existed within the community. We are almost out of time, but I would like to ask both of you, if I'm suffering from a mental health condition, if someone listening to this call identifies with what they've said, like we said, self-diagnosis is a no-no. Where do you think, where would you say they should, what's the starting point to getting the help that they need?
Okay, well, there are various avenues to deal with this. First of all, at the National Referral Hospital, if I'm not wrong, there is some free support. And so,
Yes.
I know there's support at Nakasero Hospital in Zambia, Rubaga, and also the Mind Lab is happy to help you find support tailored for you. So according to your preferences, age, gender, the price range, we're happy to walk that journey with you. Leona, I'm not sure if you know any others.
I know myself.
Yes. But
Important plug. Yeah.
No, most importantly, I would like to stress the importance of educating yourself. Just educate yourself. There is so much information. If you just go to Mind Lab, for example, you'll find a lot of information about mental health. I feel like a lot of people are worried about the expenses and how much it costs. That's after the stigma, of course, because how can you be seen to go to a therapist? That's a thing. In the Fortune 500 companies, every manager is required to see a therapist per week, once a week. That's a requirement. And it's not because they're mentally ill. It's just that important to process your thoughts with an independent party, especially a professional one. It's very important. And so educate yourself. If you feel like you're getting out of your regular life way, read about it, go on Google, see what you have to learn, ask. There is so many resources that are actually available. And should it get worrisome, or should you think that you need help, there is help that is available. Yeah.
Thank you for sharing.
There are some questions coming in for you in the Q&A. I don't know if I can read them, or you can go ahead and read them. Can you see the Q&A?
Please, I can't see them. Please go ahead and read them.
So, the first one, during the COVID-19 era, there are people who have only just discovered that they actually had low-grade mental disorders for a long time. Do you have any thoughts on how non-professionals who are old friends of these individuals can be the best support system for them, apart from recommending professional help, especially those who tend to be loners? That's the first question. Should I go to the next, or do we answer one by one?
Can I just answer that?
All right.
Community. Is that fine? Can I answer it?
Yeah, please.
Yeah. So community is a big part of mental health management and coping. So if you feel that your friend is struggling with depression, you can help. There's various ways in which you can help. In fact, you have an important role in helping them with their healing journey. For one, you could just listen, and active listen without judgment, without imposing your point of view, without telling them that, it's just to hold space. It's called holding space. It's important to hold space for a person, and that's listening to them without judging them, without imposing solutions. Most people just want to be heard, not to be told what to do. They just want to be heard. So one thing that you can do for your friend that would absolutely help them is to help them to be heard by listening to them and holding yourself back from imposing your perception and your solutions.
Yeah. I like what Leona said, because it encompasses, everything that I believe when people ask me the same question. I'm not a mental health professional, but as an advocate, when I'm asked that question, I say empathy is the cornerstone to being able to deal with, to be able to address mental health issues, because from empathy, that is where we are able to learn and practice, active listening. It's from that we are able to learn to hold space for people. It's from that we are able to drop stereotypes and put away judgment and etc. So yeah, Leona has that, for me, spot on.
Thank you, Liz. The next question: why do you think that the government budgets do not seem to prioritize mental health, and yet it seems that this would actually save the costs of mental health provision as stated by the previous speaker? Why is there a resistance from policymakers to create these regulatory associations?
Okay, so if I could answer that question, I mean, from a policy standpoint, we all know mental health issues are considered non-communicable diseases, NCDs, right? Given the nature of our healthcare budget, which is still, very low in comparison to other countries, it's two things. One, we don't have the money. When you sit in a meeting, with people in policy or policy or people in that space around mental health, they'll tell you for free, we don't have the money to do to help you or to even execute what you're talking about, to assist you. So all remedies really come from the community in terms of, as that's the theme of this conference is innovation, right? How can we innovate within the community based on the fact that, we don't have budget for it. But secondly, Leona and Patricia have touched on this. It's institutional stigma, right? Whilst institutional stigma still exists, we will not be able to, the resources that we need to be able to address mental health challenges will not be allocated to us. So until we address the stigma, yes, at a community and a local level, but also at an institutional level, we will not be able to receive that resource allocation, even just in terms of training and, working with healthcare providers, because institutional stigma exists. For example, in a hospital, a doctor would rather diagnose you with malaria because, than diagnose you with a mental health condition, right? So I feel like those are the policy issues that, continue to hinder the advancement of, the mental health space and mental health care in Uganda. I don't know if Leo or Patricia have anything else to add.
Yeah, I'd just like to add to what you're saying, Liz, and add that it's a lack of knowledge. It's just, a lot of stigma also just comes from a lack of knowledge.
Yeah.
People are just not aware of what mental health is. If you talk about mental health, they can only think about someone running butt naked on the street and dirty, and so because of that, nobody wants to be associated to that. Much in the same way as having HIV, because there was a lack of knowledge, it means that you're promiscuous. So why am I going to prioritize your promiscuity, right? And then if there is more knowledge about it, then people can donate money, we can get money, and then that money helps researchers, and then researchers can produce medication, professionals can be paid, and then the disease can be alleviated. Without the knowledge, we're still but it's still backward. We're still backward.
Yeah.
All right. The next question. One of the speaker slides said 49% of entrepreneurs have some form of mental illness. This is a little bit shocking. In what ways can we help budding entrepreneurs to avoid these issues early, in school or at university, for example, so that they do not escalate to full-blown diseases during the most productive stages of their lives?
Yeah. So as Martin, you and I, we like to work in the entrepreneur innovation ecosystem.
Yeah.
And I know it is in this ecosystem that we can provide communities, we can provide the support, the necessary support to be able, to tackle some of these mental health issues as they emerge. Leona touched on, how in Fortune 500 companies, managers, report to a therapist every week or every so often. But especially in the global South, like here, low and middle income countries like Uganda, first of all, we don't have the resources in the resource persons, right? To be able to offer that support. But we do have communities in terms of, say, incubators or accelerators. A couple of them have popped up now, Outbox Innovation Village, etc., where that converge so many entrepreneurs. So I feel like the onus is on them, or that they have an obligation right now to be able to put in place strategies or programs that will help innovators and entrepreneurs deal with, mental health challenges before or as they emerge. Yeah, that's how I feel about that.
All right, thank you. Then the last one is, while digital tools may not provide all the solutions to mental health issues, do you have examples of tools in use right now in other regions or even in Uganda that help to bring these services closer to the general population?
I feel like I'm talking a lot, but one of my favorite tools, and I've had the privilege of interacting with this person, Dr. Dixon Chibanda, Martin, that's his name, please remind me. He developed a program called the Friendship Bench. And that's why we said many times innovation doesn't have to be centered around technology. So basically the Friendship Bench is park benches, benches in the middle, public parks, right? So he looked at a segment, at a demographic within the population that were retired. So these are grandmothers who they call, shoshos in the southern parts of Africa. He identified those, and in African culture, we look at these people as, wise, because of age, they have wisdom to offer. So they go through a basic, training, and they wear vests and sit on park benches. And in doing so, they are able to offer a certain form, a form of psychosocial support that would otherwise not have existed, and would only be, accessible in the healthcare system. And from Dr. Dixon's story, he created, that idea came about after he lost, a patient he had been seeing for many years, that he eventually lost to suicide. And that was probably because they were not able to receive adequate psychosocial support, that they could have, received. But I'm seeing several, startups in the mental health space start to employ and engage spiritual leaders, because these are also support structures that when, if trained well on the aspects of mental health, can offer their following, their flock, a good amount of psychosocial support that, they may not be able to get, outside or, in the different spaces. Yeah.
And also to integrate mental health services into primary health care. That would be useful, Like, I think what you're talking about is building informal community mental health services.
Yes.
Yeah, I agree with you 100%.
Thank you so much, Liz, for the discussion. I'll hand over to Jackie, who is in the room, to conclude it with Liz. Thank you so much for quite an eye-opening session. And we thought that this is a very important session going forward. And we hope that from our stakeholders attending, that we can reach out to you and your team, MindLab, and the rest of the panelists to kind of engage organizations in being intentional on creating these streams for their employees, because I think it's really critical. We are seeing what people are defining as the Great Resignation. People have come to dig deeper into what work means for them, and this has resonated with mental health, what matrices people use for satisfaction, given the horror that the pandemic has revealed. And so even IDI is rethinking and really working to implementing these support services, and Jackie has been working to make sure that within the institute, within the academy, these are open conversations and support is available. So it will be great to include these sessions in most employment places, such that it no longer gets the terminology of madness or you being weird when you really need help, because 90% of the time we are either out of our homes working or engaging in some other activities that give us a livelihood. So thank you so much. Over to you, Jackie and Liz, and I'll take it after that. Thank you so much.
Thank you, Martin. Thank you, Martin. Thank you, our dear panelists. It's been a very good discussion. There have been good deliberations, and yeah, there are very many things to think about. Some have been mentioned. So just a reminder to all of us to think about these things. I remember Liz asked us to just mention what we are feeling right now, just something to say in the chat. Well, even if we did not have people type in that, but it's just for you to think about and know your mental state or your mental hygiene. So, and it's true, there are very many myths surrounding mental health. We have very few psychiatrists or psychologists, clinical psychologists, and even then they venture into different fields because they feel they haven't been recognized. Yet there's a lot of work that has been done. We've seen psychologists being employed to do neuropsychological tests on children after cerebral malaria or very bad illnesses. But then we don't see how this transforms into a psychological thing, but it ends up being a paper on just malaria and not the other way around, yet they're actually the ones who are doing all these assessments. So there is room to think about all these things, and I urge the government or the people who are listening to us who can take word that it's really important. At least let every organization have one psychologist to start with. It's very good for you to know your mental state. You may not know, but someone else can tell and walk through with you to actually eventually accept that you're not well and get treatment before it goes so far. So Liz, thank you so much. With the panelists, I'll hand over to you to close. If you have a word or two, Leona, Patricia, a word or two as we close. Thank you.
So my parting shot really is, wow, it's been a very insightful conversation. It's always a privilege and honor to sit with other professionals in the healthcare space to deliberate on how we can address the mental health crisis. I keep saying it's the next pandemic. We're getting out of COVID, but the next pandemic is related to mental health. So how do we build that resilience, to prepare ourselves for that pandemic and get through it effectively, right? So for me, conversations like this are very important. The the most important part is how do we the actionable steps, right? Tangible solutions that come out of these discussions for us to, go out into our communities, into the spaces in which we work, and help the people that that we serve. So thank you to IDI, to Martin, especially, who has been on my case so much to deliver on this. And I look forward to further engaging with IDI on, issues around mental health. Those are my parting shots. I'll leave the rest to Leona and to Patricia.
My parting words would be to the people listening to not just be people listening, but to be active, to actively value themselves and their mental health, because you can't actually value another person's mental health if you don't value your own, right? You have to first learn how to hold space for your own self before you can hold space for another person. You're not as forgiving as you think you are if you cannot forgive yourself. You're not as kind as you think you are if you're not kind to yourself. The focus should be on your thoughts. If you can learn to manage your thoughts, every human being has up to 60,000 thoughts per day, right? And 80% of those thoughts are negative. So people who say positive vibes only, that's neurobiologically impossible, So if you have that, and 95% of your thoughts are repetitive, so the majority of the thoughts that any human being has.
Can you just come again on that? Because I think that is, we need to highlight some of these things.
Sorry, I was saying every human being has up to 60,000 thoughts per day. Every human being. And that's a regular human being, by the way, not one that is stressed. One that is stressed is having much more than that. But every human being has up to 60,000 thoughts per day. 85%, which is a big majority of those thoughts, is negative. They are negative thoughts. And 95% of your thoughts are repetitive. So it's really those negative thoughts repeating themselves. And it's not because it's the demonic or anything. It's because it's just how your brain is made to protect you. Your brain is just trying to protect you by bringing up all sorts of scenarios so that you play them in your head. And if they do come, you overcome them, right? But in so doing, there's so many thoughts that are ravaging our minds, especially as adults, and they're cumulative. And if you're working in a high stress environment, or your home is a high stress environment, I think adulthood is a high stress environment, to be honest. And so it's imperative that we learn to manage our thoughts. I think that that's the crux of the mental health issue. If we can learn to manage our own thoughts, then and understand what discipline it takes, then we can be able to affect. That's how we lift stigma.
Yeah.
That's not in theory. That's how we lift stigma.
Yeah.
Wow, I have so much work to do on myself. Thank you for these are revelations I would never ever thought of in my medical practice. I've never thought about that at all. But thank you. This really makes a lot of meaning to the work that we are doing and how we have to take care of ourselves. There's Kawayo.
I don't know if she's still on.
Kawayo? She is. We can't get your sound, Patricia.
Can you hear me now?
Yes.
Okay. Thank you, Liz and Leona and Martin and Jackie for this conversation. Mine's going to be very, very simple. It's okay not to be okay. So take care of yourself and be your brother's keeper. If you feel as though you're not feeling yourself mood-wise, appetite, sleep, all of these are very key factors. Just talk to someone. Like Leona shared, do the research. Figure out why you're feeling the way you're feeling. And sometimes the research means sitting by yourself and writing in a journal every single day until you find the triggers and the stressors, and there will be patterns. So you need to pay attention to yourself, your body, your mind, and your behavior. So that's it from me. Thank you all. Okay. Bye.
Thank you so much. We're getting feedback that you know, when you speak innovations and conferences, certain people do not relate because maybe of tech terms. Someone just said, "This is the only session I've understood." Like they really relate to, you know, we speak too many things, technical, medicine, and all these things, but we forget about ourselves.
Yeah.
And I'm glad that this has spoken to people without us focusing on work, innovations, people, us who do these things. And we are the people who matter, because if we don't matter, we can't deliver.
Yeah.
So thank you very much. Hope you can stay around. We're going to have, before we close the conference, we are going to an exhibition. We feel better, refreshed, and thank you so much. We are going to continue on this link with interesting innovations from TMCG, Rocket Health. We are going to be flying drones in the room. Can you imagine?
Wow.
Flying drones in the room. I tell you.
Health innovation, isn't it?
Trust me. Trust me.
We know you fly drones there in islands, but we didn't know you can fly them here.
You're going to fly from Kalangala in under a minute and you'll be seeing it in the room. So thank you so much. I would like to invite Dr. Ruth or Lorraine so that we can go through the last session of the exhibitions. We have works coming in from TMCG. IDI has been doing the support for COVID using some interesting applications. We're trying to decentralize access to services through some of our works. So thank you so much, Jackie, for that very wonderful session. It put a human touch to everything. So without wasting any more time, I would like to invite our innovators. We shall have Hilary Kaluma, who has been supporting, who developed together with the Academy, an application integrated with an IVR system that has been supporting the ministry in home-based care for COVID. We have Solomon Obot from the Medical Concierge Group. They developed an HIV self-testing chatbot. Hilary will combine Dr. Irene's presentation on Call for Life, the IVR system. And to close it, we shall be flying the drones. But before we start, I would like to play a video from TMCG. TMCG runs Rocket Health. And Rocket Health has been very central in responding to the pandemic. The uptake of digital services increased during the pandemic. And one of the organizations that stepped up to ensure continuity of care was Rocket Health. So I would like to request that as we're getting the other innovators ready to showcase the applications and upload them, that we play the video from the Medical Concierge Group, Rocket Health. It will be about 3.5 minutes, and then we shall come back to see other innovations coming in from drones, more from TMCG and the Academy. Thank you. Over to you, the technical team.
Hello, welcome to Rocket Health. You're talking to Dr. Stella. How may I help you today? Okay. Okay. So what we're going to do, it would be good to do some tests depending on where you are. We can actually have our lab team come to you, take off the samples, and we'll get back to you with the results. Okay, thank you so much for contacting us. We'll be in touch with you soon. Yes, good afternoon. This is Dr. Stella again. Yes, so we are getting back to you concerning your results. So we can be able to deliver these medicines to you. Our pharmacy team is able to come to you wherever you are, where they pick the lab samples from. Are you still there? Yes. Yes, they'll also give you the cost and all that, and you'll discuss with them the mode of payment. Yes, thank you so much for using our service. We hope you get well soon. We'll also check on you after a few days to just see how you're doing and if there's any improvement. Thank you. Thank you so much. Have a good day.
Ekyo bakiyita Cresta.
Sorry, my boo.
So you're going to give her this evening? Yes. And tomorrow you give her morning. Can you wait?
Thank you so much. That is work coming in from the Medical Concierge Group and with Rocket Health, trying to make sure we have continuity of care, the decentralized access to services. We shall share their details in case you have people who might need to be followed up for care. TMCG has been part of this conference. They will later be showing us their chatbot. To make it quick, since we are trying to run out of time, we have Hilary Kaluma from the Academy, who will be showcasing his home-based care application for COVID. Hilary, if you can make it in under 3 minutes, I believe you can, right? You can unmute.
Thank you, everyone, for this opportunity. Good afternoon to you all. Like Dr. Martin has introduced me, I'm Kaluma Hilary. I'm currently working as software developer at IDI. As software developer at the academy. So I came in as an intern from GIZ under the Senate at EA, which is Center of Excellence for ICT in East Africa. So I'll be presenting a couple of projects for IDI Academy in this presentation. So I'll be presenting basically two projects or products. First will be Core for Life. I'll give a background about the Core for Life and where it is now and where it's going. Then I'll also try to also give a presentation to HBC, which is home-based care, the application, and its connection with Core for Life, COVID surveillance. So I would start with explaining what Core for Life is. So Core for Life is basically a web-based platform. It contains interactive voice response. Basically, it's just a web application you can host on web, but it has a voice response system which can play audios, pre-recorded audios, once it initiates a call to a patient and it asks them about their symptoms, or maybe offering peer reminders, or maybe also offering also health tips as well. So it was first adopted at IDI in 2015, and it was first used for HIV. So later on, it kept getting adopted for other diseases like TB. Then lastly, 2 years back, it started working with COVID-19. So under COVID, it has two different variations used in. There's what we call surveillance, where it initiates calls to patients who are under treatment of COVID in the first 2 weeks of since they are discovered to be positive. Then there's psychosocial, where calls are initiated to patients after they have finished their treatment and getting feedback from them on how they're being received in the public. So Core for Life is built on an open source structure or application, or you can call it a tool called Motec. Open source in nature that the code, you can adjust it. However, you have to fit in already existing structure. And the advantage with this tool or application is it allows you to pre-record voice recordings and can initiate calls to people or the patients for this case, and you can play those audios and get feedback from the patients. So just like the illustration I'm having right here, we have automatic calls initiated by Core for Life system, and the patient can be able to receive them. And once the patient receives them, they can listen to the pre-recorded audios, asking for maybe symptoms from them or giving them health tips, and they can be responding by putting input based on what the call recommends. It can, let me give you an example. It can request them maybe to put in 1 if something or a symptom is applying to them, or 2 if it's not applying to them. And once they put that feedback, it's taken back to the Core for Life system and saved as alerts. So then the other system I want to talk about is the Core for Life COVID with HBC. The Core for Life COVID is a project I was working on when I came to IDI as an intern from GIZ and Senate at EA. So the project, the idea was basically originally Dr. Martin's. So he presented a couple of ideas to me. So we tried to come up with ideas, but I like this idea out of all those ideas. So we try to brainstorm on it. The good thing is Dr. Martin had a whole overview of the idea, but the details is what we had to work on. So we had to fill in the technical details. And once we came up with a more clear understanding of how this system could actually work, then we got other teams on board like Francis, who was very helpful technically and still helpful in the project till now. So we got Francis Musinguzi on board, and he was of much help to the realizing of the whole idea to at least where it is right now. So with the COVID-19 crisis ever since 2019, like the previous speakers have talked about health, psychological or mental health, there have been a lot of health challenges, not only those ones of mental health, but even in the public systems and health centers. There has been need to create alternative methods or means of offering healthcare to patients out there due to the limitations the systems and most countries, or most of us have discovered with already existing health systems. For example, if you were to have 1,000 people, okay, very many people get sick at the same time, you will find out that the health systems you're having or the hospital will be filled. And even countries like China, which have much capacity, even after building a lot of big hospitals quickly, still they had a lot of serious challenges with influx of patients, especially in times when we have spikes or waves in COVID. So home-based care generally is a health system where patients are offered treatment or care from their localities or their homes. And it has actually existed even before the original hospital-based system offering treatment. So in this project, we try to explore home-based care as an alternative to the original hospital-based system. So this is just an overview or an illustration just to give us a hint of how the Call for Life system works. So you have your patients in your localities or their homes. Then you have the home-based care app, which we designed, and you have a healthcare worker at the hospital. So once the healthcare worker at the hospital maybe tests someone, finds them positive of maybe COVID, then they can add the patient or the person positive to the system, to the application. They get the patient's biodata, like their name, their location, their age, and other important information, and submit it into the app. So that information is stored in the back database of the application. And the idea we have is to have that information interoperable with the already existing Call for Life system. So this information can be shared with Call for Life, and the Call for Life system will just pick these patients, consider them as patients of Call for Life, and will do automatic initiated calls to these patients to follow up maybe on their symptoms or even remind them to take pills, just like the Call for Life system has been working. So the way the Call for Life system has been existing, and it will have its initiated calls, which will be routed at the telecoms and will go to their respective patients and will get the feedback back to the application. And once, if an alert is raised, that's if someone reports a symptom, it's raised as an alert on the Call for Life system, and the medical personnel at IDI can reach out to triage the patient or even get more details or even offer advice. So that's it on my presentation. I can go ahead and try to maybe elaborate some of these things. I'm going to elaborate both the Call for Life on an interface, the web part of the Call for Life, and also the HBC application. For those who may not be very familiar with Call for Life, this is what it looks like once you are in the application. So this is just an instance.
We can't see what you're sharing.
Of the application. And on this, you can, once you are a healthcare worker, sorry. Sorry. This first. I'll go ahead and present the application, the Call for Life application. This is what it looks like once you log in. So the patients can be added on the system, you put the phone number and the preferred language, which the system has to call the patient in. So once you have that, you can go next and put more details to the patient. However, I'll use an already existing patient I created. That's my sample. So on this part, you can, in the profile, you'll be able to add information to the patient. And here you can probably edit. This part has details of the patient. And the main point, I think the most essential part here is the one where we schedule, you put in the best time for the call. Maybe I can put one close to now. So you can, the best call time you prefer, the person puts in the system is the time you initiate, the time you intend the system to call you. You have to select the best time because you may call someone or a patient at the time when it's not very appropriate. So on top of that, so you can be able to view alerts if you're health personnel. Once the system calls the person and they put in any symptom or they report any symptom, then you have alerts reported on the system, which have details of the patient's alert they raised. Then you probably there's also reports, which this case I'm not having any because it's just a sample. Then probably also the profile where you can adjust information to do with the system. However, I would just end here for the Call for Life system. It's a bit simple. It doesn't have a ton of details, but it's very efficient. And I'll go ahead and present also the HBC app and explain how it relates with Call for Life. So this is the HBC app, and this is what it looks like. So first, you have like a home page which loads, which is the login page that you see right here. Then you can be able to log in into the application if you have an account. And once you log in, you should be able to see the patients that are attached to the health center in which you as a healthcare worker is attached to. So the health workers are the ones supposed to be using the applications as it's designed for the health workers. However, the details of the patients you view are the ones that belong to the health center in which you're attached to. We got this because in our meetings with the Ministry of Health, we got recommendations that Uganda's health system is built mostly on the original health centers. So we try to make sure we make adjustments to the application to attach the patients and the healthcare workers on the regional health centers or preferred regional health centers. So on top of, once you log in, you can, when you click on a patient, you can see details of the patient, like the biodata, any relevant comments, then also the alerts which were raised on the patient and details about the alerts. So you can see also the origin of the alert. For example, VHT alert is assumed right now as the alert initiated from the application itself. Then you also have Call for Life alerts, which are alerts from the Call for Life system we presented earlier, which is right here in the background. So on top of that, you can see details of the raised alerts. You can see exact symptoms which the patient experienced on the system. You can also be able to respond to the alert. Like Call for Life, you should be able to respond to alert so that once a patient raises an alert and the doctor is calling them to maybe find out more information or even give them advice on how to deal with it, then you have to be able to edit the alert. So you put those comments. For example, if you call the patient and the patient is not on board, was not picking, then you can just write the first comment that patient not reachable. You can change the status of the alert to maybe in progress. Then you can be able to update the alert in the system. On top of that, there are a ton of other things you can do. You can add patients to the system. like in our previous meetings or the corresponding meetings we have been having with the ministry, they recommended that the patients should be owned by the application, which means the point of entry into the system should now be the application. Once you're tested positive of COVID-19, then the healthcare worker registers you into the application by putting like your names here, your phone number, the patient's age. The phone number is important because what's called for life we use for initiating the calls. Then the gender, the disease, obviously it's COVID for this case, and the test status, which probably will be positive. And you can select the location. You can start with the district, and you can select corresponding probably sub-counties. You can start with maybe Rubaga, for the case. Then you can have corresponding parishes that belong to the sub-county you selected. Let's say maybe Rubia. Then you can see corresponding villages that are attached to, that are in that parish. Then you can go ahead and specify the time, base contact time of Call for Life surveillance. You can put the hours, let's say it's midnight, maybe 40 minutes past midnight. And also put details on psychosocial, the same way we have done like for surveillance, and be able to register the patient to the system. The Call for Life system initiated like the previous part I showed, I alerted the call time, and right now I can actually have a call, but I'm having this call because that's the system calling, but I'm not going to show details. I'll elaborate it in a picture and an audio recording to show the details, but at least we can see it receives the call once you specify the time. So let's go ahead. So on the application, we're still going. So you can show alerts, different alerts belong to the different patients. You can go ahead and search the specific patient you want. Let's say, even though you just put 2 initials of the patient, you can see details of the alerts raised on that patient. You can also go ahead and view them like the previous part. Then you can also deactivate a patient. Oh, you can also carry out daily checkups to that patient. You can select the patient on the system. You can go ahead and put in temperature. If you have the temperature gun, you can put in the alerts or symptoms the patient is reporting, and you can go ahead and submit them. And this is what creates what we call the VHT alert on the system. Then you can go ahead and deactivate a patient from the system. Probably if the patient maybe gets well and or gets evacuated, then you specify where you are getting evacuated to. Then you can go ahead and submit that information into the system. So on top of that, you can add facilities to the application or to the system. You just have to specify the facility name right here and put details of where they're located. Just like the previous page was showing, you can put the parish, the sub-county, then you get corresponding parishes belonging to a sub-county, then you add that whole center.
Thank you, Hilary. I think you've tried to elaborate.
So you can do that. You can also add the health facility. Then you can be able to also probably use maps, but I'm not going to explore it so much because this is an emulator. It won't load the map of this location, but we tested on the real application. It loads the application it loads the map in which the person is located in. So on top of that, you can contact, can put a toll-free number right here, which person can contact maybe for support in case the application is having any challenges with the application. Then you can also go ahead and probably email the support team. Won't wait for that to load, but it works fine. So on top of that, yeah, I think that's it. Yeah, on top of that, the application keeps information to do with the user's account. So once you log in, it keeps the information and uses it to match with the patients that relate with the information you have. For example, you relate with the health center in which you are in, and that's the information it actually shows you. I think that's it for the app. And that's how it looks like, and that's how it works. Any further improvements can be done. And yeah, well, that's it.
Thank you, Hilary. Thank you for that quick one.
I'd like to end there. thank you for listening. Unless you have any questions.
Yeah, I have a question. Sorry, Martin, I'm in the room, but I have a question. So Hilary, can you tell us, we all know about Call for Life. What functionality does the app add to Call for Life, or does it just make it more mobile? Like, what is it adding to the existing system? Oh, I'm sure we can take it here for mine. Okay, so my question is, thank you. Thank you. What functionality does the app add on top of the existing Call for Life system that we don't already have in the web-based system? Or is it just that it makes it more mobile and easier for healthcare workers or for pharmacy attendees in remote pharmacies to use?
Okay, thank you for that question, Dr. Rosalind. Yeah, like you said, there's that part of it making it maybe more accessible to maybe health facilities out there in the locality, but it has a couple of other advantages on top of just that. First, it has a bit of implementation of a local storage, which meaning that even though you were to have like no network where Call for Life calls have to get initiated, then you can be able to have checkups initiated from the application. On top of that, you can also go ahead, which are right now functioning a bit halfway, but you can also be able to go ahead and register patients locally. Yeah. So on top of that, you have locality, have flexibility. Then if all this was to be implemented in health centers out there, it would be way cheaper to use a mobile phone that someone already has than to buy a laptop to use like maybe Call for Life web version of the application.
Okay, great. Thank you. Thank you.
Thank you so much, Hilary. And
any other questions?
We would like to go to the next presenter, Solomon. I don't know if he's online. To quickly in like 3 minutes, give us just a brief summary of the chatbot for HIV self-testing. Solomon, are you there?
Yes, I'm available.
Kindly, in under 3 minutes, is it possible for you to just showcase us what the chatbot is? Because we need to do a wrap up, and the drones people need to do their demo.
Yeah, sure. Yes, so let me share my screen. Okay, Hi, I'm Solomon. My name is Solomon Vaught, a software developer at TMCG, Rocket Health. And today, just a brief overview of what TMCG is about. So we are a digital health company. We do design and develop digital solutions for companies and related services. So today's presentation, I will talk to you about the HIV self-testing kit chatbot, which we developed for one of our partners, that is Path Uganda. But just small background. Okay, just a small background. So we did.
Solomon, you dropped off?
No, I'm available. So I'm just going to give you the demo of the chatbot.
Yeah, I think if you can go through that as quickly as possible, we'll be really glad.
Yeah, sure. So this is it. So the demo, the chatbot is currently being hosted on Facebook. So it's a messenger-based chatbot. So the Facebook page is called Path HIV-ST chatbot. So you can go to Facebook and just search Path HIV-ST chatbot. So this is how it looks like. So for you to initiate the conversation with the chatbot, for now, you click on this send message button. So the send message button takes you. So this overview from the mobile, from the web view is a bit different. So from the mobile view, it's going to be a big blue button saying get started. So whenever you click on that get started button, you initiate the conversation with the chatbot. So the chatbot has a list of predetermined questions which you have. So this is our onboarding process. We do collect just a few bit of bio data, which Facebook doesn't which when you request from Facebook, they don't give you. So for demo purpose, I'll just fill in this biodata information real quick. Yes, tell you to choose your gender. Yeah, this is your information number, your phone number. So we do tell guys to consent. So in case for the previous coming features of the bot where you'll be sharing your results of the HIV self-testing kit. So we do say before you proceed, we'd like to use a phone number to further contact you about HIV prevention services through SMS. So you consent to this. If you don't consent, you don't receive messages. But if you do, for the demo purpose, I'm going to consent. That's it. So this is the main menu of the bot. So this is the main menu of the chatbot. So the main menu we have, the first is where to find free or page for HIV self-testing kit. We have instructions and videos on how to use the HIV self-testing kit. We do have a section on, this is for sharing your HIV self-testing results. And then just the general FAQs about HIV self-testing and HIV. So I'm going to start with this, the FAQs. So you just click on the view FAQs and returns you a list of just frequently asked questions about HIV. So what is HIV self-testing? Is it the right option? Which HIV available? Just a bunch of questions. So if you want to learn more about the question, you want to read more about the question, just say, tell me more, and it returns you the question and the answers. Yes. Also, let me take you back to the main menu again. So in the main menu here, we do under instructions and videos. So we do have instruction and videos regarding two types of kits. So the two base type of HIV self-testing kit, we have the oral and the blood-based HIV self-testing kit. So you choose the type of kit you're interested in to learn the instructions of using it. I'm going to choose oral kit. So it tells you here is a short video which illustrates how you can use the HIV, the oral-based HIV self-testing kit. So here it sits. Let's just wait a moment. A video is going to load, which you can click to play. Here's a video. So this is a video about how to use.
I think we can't go through the video. Maybe people will be able to access the chatbot when you share maybe you can share what we can do in the interest of time. You can drop the link to the web page where they can access this chatbot, and kindly drop your contacts in the chat section, such that people can, I'm sure they will be able to reach out to you, both panelists who are keenly interested in the work that you're doing. We shall also be able to get this to host in the conference content, and we shall put your contact as the lead person, because we're running out of time. It's a very exciting innovation, and we didn't want to just rush through it, but I would like to make sure that the attendees get the best out of it. So if you can end the session and you kindly text the details to all this plus your contacts, I'll make sure I follow up with you and see how we can go ahead to curate this and share it even after here. Is that fine with you?
They have to say no. Yeah, it's okay. It's okay, Martin. Let me do that on the
all right.
I'll drop it in the chat. Okay, thank you.
All right.
All the best. All the best.
All right. Thank you so much. So to close the session, I would like to invite Dr. Rosalind to give us to introduce the drones and the presentation on the drones, the demo on the drones with the team that is manning this. We have little time and would like to close the conference soon. So over to you, the technical team. All right, so what we are going to,
But if we can have the video on in the room, then Clifford will just show us our Kalangala live drone and the components of it. But we don't have the video on in the room, I don't think, do we? Yeah, we'll put. Because we need to close the session because Dr. Andrew is here. Okay, now it's frozen. Right, Clifford, over to you.
All right, good afternoon, everyone. Basically, this is the drone. Show me to use a mic. All right. Drones to overcome challenges and barriers. That is what this little machine is here for. Kalangala is a vast island, and West Nile is also very treacherous and very vast area. What we have intended to do is, because we want to sorry? Go ahead. All right, let me just go on with the audio. We'll catch up with the video later on. What the Medical Drones Project intends to do, or is actually currently doing, is transporting medical supplies with this little gadget of ours. So what we did was to create these little small cargo pods, which we have customized to 1, 2, 3, 4, 5, 7 vials, which we then place in, and this is then covered up and clipped on board. What a drone can do to deliver the same sample of drugs between the islands is a fraction of the time required for the boat to go across, and for medical personnel also to transport themselves across the various islands. We have so far done 8 flights in Kalangala. This was when the project started in September. We did 4 flights on the first day and another 4 flights on the second day. We are carry on with our flights this month, and we intend to increase the number of flights that we can do as much as possible. This will also increase on the number of medical supplies that we can ferry. The beauty about
Hello. Hello. Apologies for the technical glitch. I'm trying to fix this. Hello, can the attendees hear me?
Martin, we can hear you.
All right. We lost connection from the main room. The video is off. Hello, Hector.
Will not penalize me for supporting a countryman. So Harold Wilson was a former Prime Minister of the UK. He said that a week is a long time in politics. I want to modify this quotation by saying a day is a long time in the innovation space. And the reason I'm saying that is all of you delegates have, for 2 days, invested your time and effort to sit and learn. You have made a conscious effort to give in that time. In those 2 days, I'm sure there are some innovations that were discovered while you're here. But I want to encourage you that the 2 days you spent here are worth it. And I want to congratulate you for making that investment. I have to confess that I mostly joined the sessions yesterday. This morning I had to be part of some of the events in the Science Week, including those that are happening at the Kololo grounds. But I can tell you just from yesterday, the things I learned personally, and I believe I speak for many of you, that this has been a time to share, but also a time to learn. I wanted to share with you some things I learned yesterday and some things that I've learned from others in conversation about what they learned from this meeting. Yesterday, I was amazed, for example, to hear more than one speaker emphasize that technology like these drones, you see this drone, sometimes we're mesmerized by the technology and think that it is an end in itself. I can tell you this drone looks impressive, imposing. You might even want to buy one to keep on the shelf, keep looking at it. But the drone is not an end. It's a means. So I want all of us to reflect that this technology is really a means. What's really important are the challenges that are out there that people need solutions that the technology can address. So personally, the key lesson I really took away yesterday was that it's important to identify worthy problems so that we can then apply the technology to those worthy problems. So that's one reflection. There have been many other reflections. I'm sure each one of us has their own reflections about what they learned, about the importance of stakeholder engagement. I have had multiple conversations with the director of the academy about the complexity of some of these projects, like the drones, where you need many players across many industries to make it work. We've heard about the fact that data is quite central to all of these things. And I think you've seen our colleague who was showing you the applications. Applications are beautiful things, but really it's because of the quality of the data that makes it work. So data is central, but let's also remember that data is owned by someone. The data belongs to someone. The patient data may belong to the patient, and therefore we have to appreciate that we need to work within the data protection frameworks. So that's just a flavor of some of the lessons we've learned. And as I said, I want to keep my remarks brief. If I invited each one of you to share reflections, you will have some reflections. Right, and the sense that I got, and some of this is in conversation with the director of the academy, this is the third innovation conference, correct?
Mm-hmm. Yes.
So we had the first innovations conference. It was really a new field. As an institute, we're entering uncharted waters. We then had the second conference. So this is the third conference. And the sense I get talking to different players is that this field is growing pretty rapidly. And what is exciting is that there's a critical mass. There's a critical mass. If you've ever sat in a plane going to a journey, there's that time when you are running on the runway, and then there's the takeoff point. So I want to say, I think this field of innovation in Africa is at that point of takeoff. And I think I wish I was younger, then I would invest my whole life and career in innovations. So looking at the room, I see young, people who are much younger than I can't see the ones online. I can look at the names. But I think that this is an exciting field. It's an exciting moment, and I hope that we can take advantage of it. So in closing, the question I have for each one of you, the question I have for the leaders of the academy, Rosa and Ruth, the question I have for our partners, what next? What next? We met for 2 days. We could choose to squander the momentum. So the plane has been on the runway, and we could switch off the engine. Now that would be tragic. What next? I think what's next is to really harness the partnerships that we've seen in this meeting. Yesterday, I managed to log into a talk by a colleague from the World Bank. It was amazing to see the conceptual, how much work they've already done. So I really think that when it comes to innovation, you need to collaborate and network. So I encourage us to seize the momentum. Let's reach out. There are new partners we've learned about. Let's reach out and see how we can harness that. Let us document. This meeting has generated a lot of excitement. For me, one of the excitements of this meeting is that we've had a successful hybrid meeting. And yesterday I was convincing my colleague Richards to get a publication about how to host a virtual and hybrid meeting. That's one form of documentation. But the other form is to really make sure that the material generated from the meeting is accessible, whether they're short videos, written reports. That is what's next. So in closing, I would like to appreciate. And I wanted to use this moment to recognize Diana Simon, who worked with us and who's here. And deserve the first appreciation slot to you. Thank you. But there's a whole host of partners and parties to really appreciate. The first one is really the vision bearers for these convenings and this work. And so I want to appreciate Rosalind and Ruth, who are the leaders of the academy, for putting together a compelling
But others, Pharaoh,
So,
Francis,
yes. You know, it's easy to come to a meeting, find things arranged, technology working, and take it for granted. So we want to thank, this is a deliberate thank you, very deliberate. And I encourage Rose and Ruth to find a time to appreciate the organizing committee. Yes, and I'll be happy to facilitate this. This is very important. I want to appreciate the IT team because this is a hybrid meeting. So can we have the leader of the team at least take a bow on behalf of the team? I have encouraged Richard to document his experience from an IS perspective because I really think what we've learned doing this kind of things, there are many partners who can learn. So thank you very much, Richard, and your team. IS is a team that works behind the scenes. And when things are working 99%, everyone takes it for granted. And then when that 1% doesn't work, so please, let's really learn to appreciate our silent partners. If you look in your folders, there is a program in there. And just to say that you can see that we attracted a host of compelling speakers. I want on behalf of the organizing committee and the academy leadership to thank our speakers. The speakers make the program. And like the Honorable Minister who honored our invitation, it really matters. And I again urge us to write them and thank them for contributing to the program. Of course, I want to thank our funding partners, Janssen, Johnson & Johnson, UNCDF, Pfizer. Also want to make sure I'm not forgetting the IDRC. Without their support, it would be difficult to get this work done. And I also want to thank our partners in the districts and other places where we are. I can't thank everyone. I just want to also thank our comms team that supported the work, as well as the leadership of the university, the senior management team, encouraging their teams to participate. On that note, I want to pledge the Institute's continued support to the work of the Academy and to harness the momentum we have with the new leadership in science and technology in this country, and also to say thank you and declare the meeting closed.
Thank you very much. And I promise if there's lunch left, you can eat lunch.